All right, I'll go ahead and get started. Hello, everyone. On behalf of all the organizers for the West Coast Vascular and Interventional Symposium, I'd like to welcome you to day 2 of our second annual event. My name is Navjeet Dulett. I'm currently a resident at the University of Arizona, and I'm the lead organizer. We're really excited for our day 2's content. We're going to be starting off with an international panel, transitioning into how to succeed as a medical student interested in vascular and interventional radiology, with also a private practice breakout session by Dr. Devu Lapali, transitioning into a presentation about ethical considerations in vascular and interventional radiology by Dr. Keller, and finishing off with a private practice panel. We're really excited for the content that we have planned today. I'd like to introduce the moderators for the next session. Shin Mei Chan, who's a MS3 at Yale University, Christy Patel, who's an MS3 at Rowan University, and also Henry Cito, who's a PGY3 integrated VIR resident at ChristianaCare. I'll invite you to start taking it away.
Great, thanks, Navjeet. It's my pleasure to introduce Christy and Shinmei. They've been instrumental in helping me plan this session. This session, again, was really popular last year, and we want to sort of bring sort of the international component so we can all learn from each other and see what kind of challenges we face and how we can best support each other. So I'll let Christy take it away from here.
Thank you so much, Dr. Sato. I'm so excited to be here, and it brings me great pleasure to start off the panel with Dr. Indrajit Mundal, who's going to speak to us about the efforts of IR juniors. Dr. Mundal is a radiology resident at Oxford University Hospitals and is aspiring to be an interventional radiologist. He founded IR Juniors as well as the UK National Interventional Radiology Trainee Research Collaborative. He currently serves as a representative on the JES and the BSIR Trainee Committee. Dr. Mundal, when you're ready.
Well, thanks for the introduction. Can you all hear me and see my slides, I presume?
Yep.
Cool. So thanks for the invitation. So my name's Indra, and I'm one of the radiology trainees based in Oxford in the UK. And I'll just be going through, or spend the next few minutes going through what we've been doing at IR Juniors to engage medical students and junior doctors in interventional radiology. So I thought I'd start with a bit of background on IR in the UK. So I put a comparison here compared to the US training. And it's not currently its own specialty, it's a subspecialty of clinical radiology. And training happens in a 2-3-3 model, so 2 years of internship, followed by 3 years of diagnostic radiology, and then 3 years IR training. And so despite the fact that it's growing in popularity, I think within medical student curricula, IR is still underrepresented, and a recent survey showed that 70% of medical students in the UK still want more teaching on interventional radiology. And so this highlights a big unmet need for medical students and junior doctors to gain awareness of IR. And so that was the rationale to get IR Juniors up and running, which we founded about 2 years ago at the end of 2019. And so it was really inspired by the great work that the RFS Medical Student Council are doing, as well as CERSI, which have been really innovative in engaging medical students. We initially started off as a series of web pages and social media presence, but we quickly expanded into running our own webinar series and events. And so from the original team of 4 medical students, junior doctors, we now have an extended team of 25 people, as well as a big growing social media presence. And over the last couple of years, we've established ourselves as one of the fastest growing national medical student organizations within the UK, with other organizations such as the Oncology and Neurosurgery organization getting in touch with us to organize events. And I think all of this has allowed us to push the boundaries of engaging medical students, not just in IR, but across all specialties in the UK. And this is just a timeline showing some of our milestones, which we'll go through in a second. So the main thing we've been running over the past 2 years are virtual events, mostly due to the COVID pandemic. And we've split that up into various clinical teachings, so providing education on clinical IR topics, helping medical students and junior doctors prepare for their residency applications. And we also run a journal club every month, where we invite experts in the field to discuss a paper in IR and build research skills within medical students and junior doctors. We've held about 40 events so far, and they've been very well attended. Over 3,000 attendees overall, with many more viewing the catch-up content on our YouTube channel. And now that we go back to in-person events, we're hopefully going to schedule 3 main conferences every year for medical students and junior doctors within the UK. Another thing that we've done over the past year is really drive forward the grassroots level engagement. So radiology societies, which are the interest groups within the medical schools in the UK, we've appointed a national lead to specifically work with them and provide them with support for running local events like careers evenings and hands-on workshops, as well as included them in the network so that we can help them with ideas for new conferences or any other projects in order to engage their medical students. And so far, a lot of them have signed up. The UK is a smaller country than the US, so we don't have as many medical schools, but we have 11 of the societies signed up so far, which is the majority of them, and we're working with the rest to try and get all of them within the IR Juniors network and continue pushing forward what we can offer. And the main thing that we've done over the last year as well is get involved in research. So early in 2021, we started the Trainee Research Collaborative, and that was joint with the British Society of Interventional Radiology. And the purpose of that was to do multi-centre research projects that were led by trainees, obviously supported by consultant attendings as well. And over the last year, we've completed 2 projects. One was a review on how COVID has impacted education and training amongst IR trainees, as well as a multi-centre project looking at the outcomes of cholecystostomy for acute cholecystitis. And we have a few more projects that are currently in development that the protocol is being written for, including an aortic dissection and a lung ablation project. But I think the main thing it shows is that a proof of concept for showing that we can get fast rollout of multi-centre projects. And I think that was really powerful because it showed us the power of collaborative research, and we're hoping to continue that and involve more medical students and junior doctors to build their research skills. And all of this ended with a research conference that we held virtually in October of 2021. We invited IR academics from across the country to talk about various topics as well. And this is something that's planning to be run annually each year in London. And then all of our efforts have been recognised by these societies as well. So we initially started as an independent group of medical students and junior doctors, but now we've essentially merged or are supported by the British Society, and we get support from the BSIR Trainee Committee in order to continue to offer events and educational initiatives. And we're in discussions to get support from the Royal College, which is the main training body in the UK for all of radiology. And so I thought I'd include this because what does the future look like? And it's an important thing to mention because similar to the US, where IR is now a completely separate residency, I think there's a push towards that. So from this year, we are going to have IR-DR integrated programs where people choose directly for their IR or combined IR and diagnostic radiology training. And the visibility of IR to intern level junior doctors will mean that the role of IR juniors will only increase. And we're hoping to continue to push for clinical IR. I know a lot of the new trainees are more clinically orientated compared to some of the more senior colleagues. And I think that's something that we really want to make sure that it's there in the minds of the future of IR. In terms of the committee, we're going to formalize it a little bit and make sure that all of the events and initiatives we've run so far continue to run each year. And we're hoping to increase our educational and engagement events as well as research collaborations, both nationally and with international groups as well. So thank you. That was just a brief overview of the activities so far. I tried to keep it brief, but I'm happy to answer any questions towards the end. And thanks for letting me speak today.
Thank you so much, Dr. Mundell. That was great. Next up, we have Dr. Jay Gudra, who's going to speak on IR training in Australia. After gaining experience working as a critical care ICU registrar in regional and underserved communities, Dr. Gudra transitioned to general surgical residency. He is now currently in his first year of radiology training. He's an advocate for the FOAMED movement and champions the importance of outcomes-based research as well as structured reporting. Dr. Gudra, when you're ready.
Yeah. Can you guys see my slides there?
Yes.
Oh, fantastic. All right. Yeah, thanks, guys. Just going to talk to you briefly about what it's like to train in IR down below. So if anyone who's made the trip before, it's a 15-hour hike just to stroll down the park. It's yeah, legs start cramping up in the flight, but definitely worth it for the views and the beach. And I guess you're probably wondering what do those guys do all down there, but this is sort of sometimes what it looks like for us after work every day. So definitely a good place to train. And look, we have a governing body which is called RANSCO, and they sort of look after us in many ways. And today I'm going to speak to you a little bit about how you can actually get into. I mean, if you're interested in working in Australia and New Zealand, then this is the governing body that you have to apply through. And so our college is actually aligned with the European Society, and a lot of our examinations and things are also training program as well as examinations very similar. And so while we do have our differences, we all still have the share for our love for memes, and that's what unites us as one big happy family. So what does the training program look like? Well, we've got this 5-year radio diagnosis training program. And so there's sort of phase 1 general radiology, phase 2 systems-based radiology, and procedural radiology is sort of heavily included amongst all year levels. And primarily, however, the focus is based on diagnostic imaging. And so traditionally, interventional radiology is something that's done dedicated and in post-training time, and so unfortunately, this is something that we, as a body, are trying to advocate for to also include these, similar to how Indrajit has spoken about the integrated pathway being introduced into the UK, and US already has the integrated IRDR residency. It's still yet to come. So this is what the pathway looks like for us. So if you're coming out from medical school, you have to do 2 years as an intern and as a resident, and it can be in anything. You can do medicine. You can even do psychiatry if you like, and then 5 years of radiology training. So the college has recently included this way of assessing people's competence, and so basically, as a junior, you're starting off as a level 1, and everything that you do requires constant direct supervision. And as you progress, your consultants, your attendings, would sort of like increase your entrustability level. And so level 4 is when no direct supervision is required. And so by the end of the 5-year training program, there is a expected level of independence for each type of modality. And so, as you can see here, that you're expected to be independent with most things. And this is for other modalities too. So, for example, looking at ultrasound, you can see that we value ultrasound skills very highly, and by at the end of phase 1, within the first 3 years, you're expected to be very independent with that, and more time is given for women's and kids imaging, and likewise with procedural radiology. By phase 3, you're expected to be able to do these things independently. So what sort of things are they? Well, in particularly like if you break it down into systems, by the end of the training, a trainee should be able to be independent in performing these type of procedures. And so with regards to, like, I mean, basic cerebroangiography and vascular, you can perform basic catheter angiography, venography, balloon angioplasty, stent placement, and so and a lot of biopsies. And the more advanced stuff is things that you'd pick up in fellowship. So it's just a quick overview of what type of skills you would expect to gain during the training. So even though it's very diagnostic heavy, there is a specific procedural component, and you have to keep a log and make sure that you meet the necessary exposure to be able to be a very holistic generalist radiologist. And so this is a picture of the hospital that I was working at, Royal North Shore in Sydney. And very iconic views. 5 minutes down the road is the Harbour Bridge. And then after work every day, I would park on one side of the bridge, run across, and then take the ferry back. So absolutely a very delightful place to work. So if you're coming as an outsider to Australia and New Zealand, how can you get in on the radiology job? So basically, you have to apply for a specialist training, and there's an interview that you have to sit, and an application fee, and basically what they do is they assess how similar your training is to the RANSCA trained specialist, and that includes, the assessments, the examinations that you may have done. How similar are they, right? So and also your recent practice and your experience, how similar is it? So based on these things, these criteria, the college deems like one of three outcomes. So they say that either you're substantially comparable, which means that basically you just have to sit that interview, and now you can practice as a specialist. If you're partially comparable, that means that there is maybe a period of upskilling that you have to do, and usually this includes a period of 1 to 2 years where you have to work in an accredited training position, and then afterwards sit the phase 2 exam. And then unfortunately, if you could also be not comparable, where they deem that you require greater than 24 months of full-time equivalent training, and that person basically gets rejected. So this is all assuming that you've already completed radiology training in another country, and then you're applying. Then you apply for specialist consideration. So it's a bit like this. And so if you want to enjoy our weather and enjoy the views, there's a bit of a pathway to follow through. So if you're found to be substantially comparable, then there's two pathways there. So if you've got international recognition, then all you have to do is sit an interview with our chief censor, and then they'll give you eligibility for fellowship. But that's very rare. For most people, what you'll have to do is you'll have to do 1 year of 12 months of peer review completion. So a lot of we have a lot of specialists coming from Brazil, and basically they'll have to spend a year in the hospital, and the reports and the procedures, everything like that, gets sort of peer reviewed by other consultants, other attendings, and then they're granted fellowship. And then we also have a lot of fellows coming from the US. And again, because of a lot of people have done 4-year training as opposed to the 5-year training, a lot of people get put into partially comparable category. And in this case, many times they just have to sit the Part 2 exam as well. And afterwards, they're given fellowship. If you're not comparable, then that's a lot of trouble. You'll have to basically go and do AMC, which is basically the equivalent to step 2, step 3 exams, and then do the whole 5-year training program, and then try to do IR training. So longer pathway. So what sort of exams do we have? Well, most people will be put into partially comparable type of category, and they'll have to sit these exams. So we have a particular pathology component, which is MCQs, short answer questions, as well as clinical radiology, where they're given sort of multiple choice and short answer written type questions. And then next part is the objective structured clinical examination. So it's 7 systems, and yeah, basically somebody is going to grow you on different types of cases, and it's rapid fire, and you just got to get through them. So basically, you have to know how to get them to take the film down. That so no waffling. You have to be very concise, and it is a focus on diagnostic. So you have to be very well rounded as a generalist radiologist to get through this. In order to get to the light at the end of the tunnel. So what is the current status of IR training in Australia? Well, currently we don't have any official training pathway or certification. And normally once you become a fellow, you then undertake 1 to 2 years of advanced training, which is either an IR or INR. And this year, the college is currently working on application for specialty recognition. So we're still a few years behind, but nonetheless, we're, the reps still come here and we do all the same procedures. And so, yeah, so fellowship in IR is usually typically 1 year in duration. And normally, we're quite aligned with the European board. And so a lot of our fellows will be doing the EBIR examination, and that's hosted annually at our IRSA meeting as well. And then if you want to do INR, then a minimum of 2 years duration is required to get one of the jobs. So what is it like as a fellow, and what are the responsibilities? So I was a student here at the Royal Melbourne Hospital. It was actually where I first fell in love with specialty of IR, and I used to shadow my fellows at the time, and some of the things that they used to do were, every morning there'd be a daily ward round, they'd be accepting referrals, they would be participating in procedural sessions under supervision, and there's also like a very clinical requirement there, and if the patient deteriorated, and you'd be expected to attend and run the code blue as well, until the backup arrives. A busy tertiary hospital, there can a lot of things going on. They hold you to a very high clinical standard. You'd also be continuing to do diagnostic reporting, and usually that's like a morning or afternoon session every week, as well as supervising juniors, as well as undertaking research activities. So consummate clinician, definitely. This is a peak body for IR in Australasia. So that actually includes Singapore, a lot of Southeast Asia, and New Zealand as well. And so the website's an excellent resource. They've got a PDF with all the different fellowships, positions, and who to contact if you're keen to apply. And it gets updated on an annual basis. So yeah, I mean, we have lovely hospitals down here, and if anybody needs ideas for potential, retirement down the track, then definitely it's a good option for you. This is a Gold Coast University Hospital. I used to locum here, and 5 minutes down the road, we have the beautiful Gold Coast beach, absolutely magnificent. I also locumed at Sunshine Coast University Hospital. Again, absolutely outstanding. It looks like you're in a mall in Dubai, and I walked sort of 5 minutes down the road, and this is the type of view that I got. So definitely if you're into beaches, if you're into views, come check out Australia, New Zealand. Thank you, guys.
Thank you so much, Dr. Gojra, and sharing those views that you get to enjoy every day. Next up, we have Dr. Aditi Chaurasia, who will speak on IR training in India. Dr. Chaurasia is a postdoc research fellow in the NIH, currently studying familial renal cancer imaging. She joined non-academic junior residency in radiology and IR in Ames College from 2019 to 2020. She serves as a co-chair of the Visiting Fellows Committee at NIH and vice chair of SABI's Early Career Committee. Dr. Chaurasia, when you're ready.
Hi guys, can you see my screen?
Yes.
Is it in presenter view or the normal slide?
Normal. You're good. Yeah.
Okay. Okay.
Normal.
Thanks a lot. Thanks,
Mhm.
Christy, for the kind introduction. I'm excited to meet everyone here and talk about intervention radiology in India. As you can see in this picture, we are at the dawn stage and we are progressing steadfastly. So 1 second. So the goal of my talk would be to talk about IR in India and give you a brief overview on the training pathways and as well as the challenges faced by IRs as well as medical students in India and the kind of outreach that we have. Starting with the training pathways, in India, we enter medical school after high school, which is roughly around 6 years and includes 1 year of internship. It's followed by an entrance examination, a postgraduate entrance examination, followed by which you do a 3-year diagnostic radiology residency. Among the people who have done the residency, a select few would choose to subspecialize in intervention radiology. So it's a subspecialty in India. Coming to the number of training programs, we roughly have around 40 training programs and each offer around 2 to 4 positions per year. The duration of the training program right now is could last from 1 to 3 years, and it's highly variable depending on the kind of facility and the kind of patient population you see. So, but there has been a recent push by ISVIR to develop a standardized curriculum of 3 years, which will be uniform across the country. So is IR gaining popularity in India? We can definitely say that the awareness is increasing and among other clinicians as well as radiologists, it's becoming more popular. And among patients, it's still a work in progress. And we are continuously trying to increase the popularity among patients as well. So what are some challenges to recruit future IRs? One of the biggest challenges that we have right now is lack of awareness among medical students and IRs, because very few institutes would have a teaching, like very few teaching hospitals would have an IR department. And even those which do have an IR department, there is no particular curriculum to have radiology as a mandatory elective rotation. So it's mostly elective. And even within that, if you do not have an IR department, then you are not really exposed to IR. So most the lack of awareness makes medical student completely clueless about what IR is. Another major challenge is that radiology in itself is extremely competitive. So it's one of the topmost branches. So in India, it's based on your rank or your examination score. Essentially, you have to give a postgraduate entrance examination, and based on your rank, you get to choose your branch of your choice or your city of your choice. So based on that rank, and radiology is like among the top 3 specialties. So like even if you are interested or if you're exposed about IR, you may not really have a chance to practice radiology and then intervention radiology. So another challenge we have is that people who choose radiology and the kind of population who wants to go into intervention radiology is diagnostic radiologists. And the students who have chosen diagnostic radiology often choose it because of the lifestyle benefits. And they are not usually the ones who necessarily would want to go into a procedural specialty, having on-call duties or having to establish a practice. So these are people who are comfortable, who after graduating would have a comfortable lifestyle, and hence they are very reluctant to make the decision to follow into IR. There are, along with that, there are several myths and perceptions of students and residents who are exposed to IR. For example, potential scope, difficulty in establishing oneself, radiation exposure, and so on. There are these myths and perceptions often hamper them from choosing IR. What are some of the challenges do practicing IRs face when trying to grow their practice? So cost of procedures is one of the biggest limiting factors when it comes to practicing IR in India. So in India, we do not have an insurance system, and often patient pays out of their own pocket. And an average patient's average income would be around $160 per month. It's like give and take. Or so it makes the procedure of, for example, uterine artery embolization not affordable for them. And in India, cost, affordability, and accessibility becomes the primary factors in deciding what a procedure a patient will undergo. So for example, uterine artery embolization would cost roughly around $2,900 or $3,000. I'm telling in dollars because for INR, it would be easier to understand in dollars. So it's roughly around $3,000 for a uterine artery embolization. But for example, a myomectomy or an abdominal hysterectomy would just be roughly around $100 in a government setup. In private, it's a little bit, both the procedures are similar in price, but for government setup, which is more accessible and affordable, is just $100, and patient would want to go for that procedure, which is less expensive. Compared to US, definitely India is much more cheaper in in performing both UAE as well as surgeries, as you can see. Coming to the cost factor, like elaborating a little bit more on cost factor, why it's so expensive is because in IR, we have a lot of consumables and a lot of equipments which determine the overall cost of the procedure. In India, the overall hospitalization costs and the peripheral expenses are significantly less, and it's even more so in the government setup. So the ultimate cost or the total cost of any procedure comes down to the consumables. And since IR uses a lot of consumables, here is where we are limited in terms of patient outreach. Surgery has significantly less number of consumables. So that's why the overall cost of procedure is less, even though patient is hospitalized for a longer time. Another challenge is that we have less trained IRs. We have around 600 IRs for a population of 1.4 billion. But as we are as there is a push to increase the training programs as well as having a standardized curriculum, we could hope to increase more trained manpower. Plus, I think it would be good to harness the potential of medical students to go directly into IR. Another key challenge faced by practicing IRs is lack of awareness. So whether be it patients or students or other physicians, there is a lack of awareness in terms of what IR is and what IR can offer and how IR can help patients. So this is one of the key factors in terms of IRs having to establish their own practice. Having said that, let's discuss about the potential. So India has a huge potential, a tremendous potential in serving this massive patient population. We are one of the countries with large diabetic population, trauma, venous diseases, oncology has untapped potential, fibroids, nephrodialysis. So there is just no shortage of patients and procedures. And once you establish your practice as an IR doctor, you could serve a large amount of patients. Recently, ISVIR and many IRs in India are doing a fantastic job in propagating what IR is. They are using Twitter, using social media such as YouTube, and especially newspapers and radio stations, which are commonly used by the public of India. They directly approach the public of India, public, to increase the awareness. For example, laparoscopic surgery. So laparoscopic surgery was not really popular. It was a little bit more expensive than the open procedures, right? But these days, everybody has heard, most of the people have heard about laparoscopic procedures. They are there in even smaller towns, and people prefer laparoscopic procedures for, say, appendectomy. So it's only a matter of time when IR is also in that stage where we can confidently say that since people are aware about IR procedures, they would rather go to an interventionalist for a minimally invasive procedure rather than doing open surgery if we handle the cost factor. Another potential for IR outreach in India is direct communication with patients. So in India, a person can directly go to a neurosurgeon, or they can go to a neurologist, or they can go, there is no need for a person to go into a primary care physician first. So what would that mean? That means that if you actually raise patient awareness, or if the public is aware about the kinds of procedures you do and the kind of help that you can provide, the patients can directly come to you. So if you spread the message to the public, you would not have to set up your own referral base. The patients can directly come to you. So are there any international collaborations between IRs in India and world? So for example, SIR, CERSI, they have their annual meetings, and ISVIR, the IRs who are members of ISVIR, they get affiliated memberships, and they have discounted meetings to attend annual meetings. Also, some of these societies also have sessions geared towards, for example, ISVIR meets CERSI, and such sessions to like to promote collaboration. But in terms of research or an official training, exchange training, we are yet to establish that collaboration. Summarizing, IR is a subspecialty in India right now with the variable training curriculum, which we are changing. There is an increasing trend in the availability and popularity of IRs, and the major challenges are high cost of procedures and lack of awareness. And how we can handle this is by fostering collaboration and addressing these challenges. And in this way, we can enhance the IR outreach. Thank you, everyone. And I would like to give a huge shout out to ISVIR India for doing a fantastic job, and my IR friends who helped me make these slides and then help me decide like what kind of problems that IRs in India face and how we can improve upon them. Thanks, everyone.
Thank you so much, Dr. Chaurasia. I will now pass it on to student Dr. Shinmei, who is a third-year medical student at Yale University.
Thank you so much, Christy. I have the pleasure of introducing our next speaker. Fabian is an assistant professor at the Yale School of Medicine. He graduated from medical school at Ludwig Maximilian University in Munich, completed a surgical intern year at Cornell Presbyterian Hospital in New York City, and completed diagnostic and interventional radiology training at Yale New Haven Hospital, where he served as chief resident in 2020 to 2021. He is also the co-founder of Road to IR, a collaborative effort between Mumbili University of Health and Allied Sciences, Yale, Emory, and other institutions around the world, which has developed the first accredited IR training program in sub-Saharan Africa. Without further ado, I'll turn it over to Fabian.
Thank you so much, Shinmei. I hope my sound is okay. If you guys can't hear me, let me know. Like I said earlier, I'm tethering for my phone, so that's a problem. All right, so there was that prior talk was very interesting, actually a perfect setup for my talk. So as we heard, there are many parts of the world that really have a lack of IR, and this is really most pronounced in sub-Saharan Africa, where you have 1 billion people with almost no access to interventional radiology. So there are less than 20 interventional radiologists in total in sub-Saharan Africa outside of South Africa. That means that even some of the most basic IR procedures like, corneal biopsies, abscess drainages, nephrostomies are simply not available to almost 1 billion people, which is really insane and causes a lot of unnecessary suffering and death. So I'm going to talk today in particular about East Africa, but the same really applies to the rest of sub-Saharan Africa. So in East Africa, you have several large countries, including Tanzania, which is a population of 60 million, and the status of IR in 2007. So there was no IR at all. Time had 5 interventional radiologists, but no training program. Uganda, with 40 million people, had no IR at all. Rwanda, with 10 million people, and Burundi, with 10 million people, also had no IR at all. So if you compare to the US, in the US, you have about 3,500 interventional radiologists for 350 million people, which means that you have about 10 per million population. And you compare that to East Africa a few years ago, where you had 5 interventional radiologists for 170 million people, which means you have 0.03 interventional radiologists per million population. And the obviously, that's a big issue. And the goal of the Society of African Interventional Radiology and Endovascular Therapy is to bring it to at least 1 IR per 1 million population. So, we're quite far removed from that. And why is there such a lack of IR in sub-Saharan Africa? There's a lack of expertise, a lack of awareness among other physicians and health ministries. There's a lack of training programs, or essentially no training programs until recently. There's no equipment. There's no equipment because there's no sufficient market. But obviously, without equipment, you can't do any IR. And then, of course, IR has high initial costs, as we just heard in the prior talk. And there's a lack of funding sources. So what would we do to try to overcome all of those issues is we said, okay, let's just get started in Tanzania and to try to train 3 residents, 3 nurses, and 3 techs. And we did that by doing teaching trips every month for 2 weeks, starting in October 2018. Every teaching team that goes there is composed of 1 faculty, 1 nurse, and 1 technologist, and then often also a medical student or resident. And the equipment we initially got through donations, but then going forward also more and more through procurement. So you can see here a little graph outlining all the people that went to Tanzania over the past 3 years, composed of like attendings, techs, nurses, trainees, and medical students. You can see there was a little dip there in 2020 due to COVID, but that we've bounced back after. This is what the schedule looks like for the visiting teams. So usually for a week, I know during the week just do cases on Fari. And so how do we organize this entire program? The way it works is that we really have to rely on a lot of communication to get these groups over there. So we use a lot of WhatsApp and Zoom calls leading up to these trips. We then have an onboarding checklist that everyone has to run through, making sure they have their flights booked, visas, vaccinations. And then we really always have to be flexible. There can be political changes on short notice. There can be, disease outbreaks such as Ebola a few years ago. So we had to cancel some trips on short notice back then. And then, of course, there's been COVID, which really has forced us to adjust quite a bit. Now, in practical terms, so I'm actually in Uganda right now, where I flew over to Tanzania last week. This is my wife here, who stopped over in Germany, picked up some equipment from some friends there that they got donated from BARD. We then flew down to Tanzania. So you see us here arriving in the middle, and then we basically went right into the procedure room and started doing procedures. I'm here right now with one of my colleagues, Dr. Perez Lozada, who's also from Yale. You can see this is one of the procedure rooms, a pretty nice setup. This is like a biplane Siemens room. Here we're doing the fistulogram. And the training pathway in Tanzania is modeled after the training pathway in the US. So after medical school, they do the intern year, then 3 years of diagnostic radiology, followed by 2 years of interventional radiology. The actual practical training, we sort of staggered in 3 phases, starting in 2018 with procedures that were most immediately needed, and then moving on to core art procedures, followed by complex procedures in 2020, 2021. So now we're basically offering the full range of procedures in Tanzania. See back here, this was sort of started in 2018, drains, abscess drainages, corneal biopsies. Then years moving on to doing like uterine fiber embolization, splenic artery embolization, to transit at this point. Here's just a little overview of procedures performed so far. So we've done a little bit over 1,000 procedures at this point, mostly non-vascular procedures, with corneal biopsy really being the most requested procedure. In terms of vascular procedure, a lot of central venous access embolizations, but also some other stuff mixed in there. And this is a really interesting graph because it shows the correlation of visiting faculty to procedures performed. So the green line here is the number of visiting faculty per quarter since 2018. And then the black bars are the numbers of procedures performed per quarter. So you can see here, so in the beginning, we really had sort of like a steady influx of visiting faculty. We started doing more and more procedures until, of course, COVID hit. So then in mid-2020, we really had no visiting faculty and the procedure number really dipped. Following COVID, we were able to send more faculty again, and we started doing more and more procedures. And now this sort of peaked in Q3 of last year, which is when we examined the first class, and the first class graduated. And now we basically have less attendings going there, but more procedures, which is basically exactly what we wanted. So now we have 2 local faculty in Tanzania, and they're able to do a lot of procedures on their own with the local trainees. So this is exactly what we wanted to achieve. Here are just a few images from the final exams that we had last year. So the first 3 graduates here after their exam. So the current status in Tanzania is that there are 2 faculty that you can see here on the left, Aza and Eric. And then there was 1 graduate, Ivan, who's from Rwanda. So he subsequently moved back to Rwanda and is now actually about to start a training program in Rwanda. And then we have the senior fellows here. So a large class with 7 fellows, 6 of them from Tanzania, 1 from Nigeria. So Fonzie's moving back to Nigeria at the end of this year. And then we have a junior class now with 4 fellows. So overall, pretty large training program, bigger actually than a lot of training programs in the US. So what's next? Like I said earlier, I'm actually in Uganda right now. So I'm just going to show a couple of pictures. We just came here yesterday just to visit the hospital here and meet some people, because we're planning on starting our training program here. in the next 2 years, together also with Greg Macris, who's a friend of mine from the UK, who some of you surely know. So here's just a few pictures from the hospital. We met with the head of the clinical hospital services here yesterday. Then did some sightseeing, went to the National Museum, went down to Lake Victoria, saw some extremely big birds there that I've never seen before. I thought they were pretty funny. And then today we actually went to the source of the River Nile, which was really awesome because I went down to Egypt a few years ago. And now it was a nice experience to see where it originates from. Very fascinating. Here's a little timeline for how we're going to do things in Uganda. So basically, the curriculum here is already submitted, and then over the next few years, we'll first bring the Ugandan trainees to Tanzania so that they can sort of see how things run there. And then hopefully, if we get the funding from RSNA, we can start sending teams here, and teams, not only coming from the US, but also from Tanzania to sort of increase the local collaboration between Tanzania and Uganda. So in conclusion, we were able to establish IR really from scratch within 3 years, and are now able to offer pretty much a full range of procedures. There's really an extreme need for IR in all of sub-Saharan Africa. I mean, you really have to be here to see it. But there are people showing up with like huge abscesses, with metastatic cervical cancer, with bilateral hydronephrosis, with cholangiocarcinoma. They're just itching, and without interventional radiology, there are really no treatment options for them. As you guys know, and as you've heard now the past 2 days, there are a lot of diseases which really can't be treated well by surgical means. So not having IR is a huge issue. Our program has a lot of research opportunities for medical students. So anyone who's interested, feel free to reach out to me. And what's next? Next is sort of copying that blueprint that we've established in Tanzania over the past 3 years. Particularly Rwanda, but then going forward, hopefully also, if you want to read more about this program, you can find us online under roadtoir.org, or you can just go on Instagram, which would for roadtoir. Thank you so much. And I hope you guys could hear me. I'm not sure how good my connection was.
Thank you so much, Fabian. And with that, I'll turn it back to Dr. Sato.
Let's see. Thank you, Shinmei. Thanks everyone for the impressive presentations from Indrajit, Aditi, Jay, and Fabian. We do have 5 minutes or 4 minutes for some quick Q&A. Let's see. Let me check the chat really quickly. If not, I guess.
Sorry, I did have one question I wanted to ask. On the chat, they were mentioning about I think Dr. V mentioned that the diagnostic residents in the US are not getting as much procedure time. Do you think that's a direct consequence of IR becoming its own specialty?
Potentially. It's something that they're looking into. I think the people going to DR maybe not as procedurally avid, and then the integrated IRs are much more hungry, or so, or starting to. The ACR is looking into this right now. They're doing a survey to see, at least for basic procedures, biopsies, drains, simple things like that, LPs, myelograms, to be able to offer that service. And now, kind of post-COVID, a lot of people are reading from home. So there's a lot less impetus for the radiologists in general to be in the hospital setting. And so that's another big reason why that divide is occurring, whereas interventional, you have to be on site to do practice medicine. So I think these are a few things, but we're gathering more data to figure out, is it really a problem and how to resolve it? How about in the UK?
Yeah, so it's similar to what Joe's mentioning in Australia, where even if you do diagnostic radiology, you have to be able to do biopsies, drains, simple vascular access. And at least in major teaching hospitals, that continues to stay. In smaller hospitals, the IRs do everything. But in larger hospitals, even the diagnostic radiologists, they do, simple biopsies and drains, and more complicated stuff is done by the interventionalists. But at least in the UK, most diagnostic radiologists are keen to continue doing the procedures, and which is why I asked the question, because I wonder if eventually IR does become its subspecialty, whether that is going to change and there'll be more of a split, or whether all radiologists will still be doing the more basic procedures?
In the US, most diagnostic radiologists, at least in an academic setting, don't do any procedures. I mean, if you walked over to one of the reading rooms at Yale and asked like a body radiologist to do a procedure, they would just like laugh you out of the room. Like it's just not going to happen. But that's because, you know, we have so many interventional radiologists, especially in academic centers. But I think that in private practice and like in smaller hospitals, or if you go to up to Alaska or something, I'm sure that you know, people, diagnostic radiologists also have to do some procedures.
Great. And then I think we have just one quick time for one quick question, just for Fabian. Monica asked, if there's a complex case, is there an option to fly in like another provider to perform a procedure?
Yeah, so right now we still have teams going to Tanzania actually every month, and basically until we graduate that large second class, the class with 7 fellows, basically want to try to have a team there every month until they graduate. Now, what happens during, you know, if there's a week where there's no visiting team there and there's a complex case, usually what we do is basically just they come on WhatsApp, they show the images, or we go on Zoom together, and, you know, an attending from the US would sort of walk them through the procedure. Really flying someone over for an emergency procedure we haven't done, but, you know, quite often what you can do is just wait a few days and sort of, you know, try to keep the patient stable, and then the attending would come there, you know, in the following week or so, and then do the case. But yeah, technically that's an issue. But, you know, thankfully now we have 2 local faculty, you know, that graduated last year, and they're actually really good and experienced. So, but, you know, going forward in Uganda and in Rwanda, we're going to face that issue.
Got it. Thank you. So I think it's 12:50. Again, want to thank Fabian, Aditi, Indrajit, and Jay for joining us at different time zones. I'm going to pass it on now to, let's see who's next. Dr. V, who's going to be starting the next session, approaching VIR as a medical student. Thanks, everyone.
And then there's a breakout session too, right?
Yeah, there's I guess concurrently a breakout session, job advice and career breakout session. I think that required a prior.
Oh, okay, gotcha.
Yeah,
sorry.
But if you guys want to head on over to that one, if you signed up for it with Dr. Villapalli, I guess that should be open, and I think Navjeet is over there.
What's the time over in the different in Australia, UK, etc.? I'd be curious. Or they all leave?
It's approaching 6 p.m. in the UK.
Wow.
It's 4 a.m. here in Australia.
Oh, Jay.
It's going to be around, I think, 12:30 p.m. midnight in India.
Yeah, that's a challenge. We invited our Japanese colleagues as well. It's the time zones are different. Why don't I get things started? Running a few minutes late, but it's kind of our second year at the West Coast Vascular and Interventional Surgical Symposium. I'm Joji Vadakacheri, program director for Kaiser LA. So, you know, just going to go back to history because you have to learn your history. Otherwise, you repeat the errors of the past, or you try to redo things that have already been done in the past. And really started in 1953, when Seldinger used this technique that's used globally now, right? All of what we could do is based on the concept of a hollow needle without cutting to the vessel, wire through that needle, catheter over the needle, and doing surgery through the catheter. But we didn't really think about surgery with the catheter until this gentleman, Charles Theodore Dotter, the father of interventional surgery and vascular interventional surgery, designed the concept in 1963 in Czechoslovakia when he was invited to the Radiologic Congress to give a talk. And that's when he said, hey, this catheter can be more than a tool for passive means for just diagnosis, but used with imagination, which he had a lot of, was a true visionary, it can become an important surgical instrument. And I don't think he might have been able to predict, but most people couldn't have predicted what could have happened ever since. So he took that to heart in January 16, 1964, when this lady, Laura Shaw, at 82 years of age, severe heart failure, really couldn't do anything, had gangrene. This is her foot, the 3rd, 4th, and 5th digits, gangrenous digits. And they only offered her amputation. And then that's where Dotter, Superman of his time, came in. And for the first time ever, used these wire and serial Teflon dilators to open up this blockage in the superficial femoral artery in the thigh. And she auto amputated her toes but she lived with both feet and walking off this earth. So, much to the chagrin, everyone hates change. The general surgeons of the time really thought this is kind of malarkey, crazy. What do you talk about? This is like space travel. This is not realistic. It's not durable. And so they didn't want us to do much with that ability or technology because they didn't trust it. They feared it. And this is an example of that. Hey, take pictures, but don't try to fix anything. In fact, Daughter did take pictures, and he didn't fix the SFA, but he did fix the profunda. They did an endarterectomy of this SFA. Patient's profunda stayed open. The SFA didn't. So just kind of that spirit of indomitable spirit of Charles Daughter still exists in interventional today. Mason Sones came out in serendipitously when he was doing an aortogram. The catheter inadvertently fell into the coronary artery and shot an angiogram. And from that day on, Mason Sones was a pediatric cardiologist. We realized we could do direct coronary visualization. And it was interesting that the first fellow of Charles Daughter, this guy, Melvin Judkins, went over because at the behest of Alex Starr, who is a cardiac surgeon who was doing a lot of aortic surgery, to learn coronary angiography and figured out a way to make it even better. And what he did was develop these catheters that are used to this day throughout the world, Judkins right, Judkins left, and an angled pigtail to do LV angiogram and coronary angiography. Pretty exciting stuff. And they co-founded the equivalent of SIR for interventional cardiology. And it's an interventional radiologist and an interventional cardiologist who jointly did it. Now, again, in the US, we did not embrace Daughter's techniques. But in Europe, they certainly did. And this gentleman, Zeitler, Eberhard Zeitler, a German radiologist, was very active in building this up. And this young Andreas Grunzig joined their forces by listening intently to what they were doing. And again, an ingenious gentleman developed his kind of Grunzig balloon in his kitchen and started utilizing this to do the first coronary balloon angioplasty. And the world of medicine was never the same. Now, when you dilate a vessel, you can tear it and it can abruptly occlude and cause a massive heart attack. The patient either dies or you have to do open heart surgery. This gentleman, Julio Palmas, in his early years, developed this metal stent, the Palmas stent, to keep the vessel open. The ingenuity continues with Kurt Amplatz, who unfortunately recently passed away, but has done some great work in structural heart disease. Another interventional radiologist, just changing medicine forever. Okay, ASD occluders, VSD occluders, Amplatz snares, and then even a lot of he wrote the Atlas of Endourology with Amplatz and Lange, where he did stone removals, et cetera. And we're coming back to that era with our new resurgence of scopes. But it's Juan Perodia and Julio Palmas who joined to the first endovascular aneurysm repair, or one of the earliest endovascular aneurysm repairs in 1990. And again, the world of endovascular repair and medicine changed forever. And this is kind of, again, all based on the Seldinger technique of percutaneous access now. But what's interesting, it may be one of you in the audience who will be the one designing the next stent graft. And this was developed before Perotti had published or presented that same thing, a patent application by a third-year medical student, Jeff Creamer, in 1986 of a similar design product. So perhaps you out there have already designed something and will be using it in man very soon. Again, we've talked about this yesterday, a tremendous amount of innovation from Judkins to Resch to Grunzig to Colapinto with the TIPS, the liver bypass, as they said yesterday, the Palmas stent. And really what got me excited about the field was this gentleman, Michael Dake, in 1994, 1999, published as first author in the prestigious New England Journal of Medicine, his seminal work on where he took a geointercozy stent, which is a metal bare stent, sutured a fabric onto it and deployed it to fix aortic dissections aneurysms, which are very risky to treat for multifold of reasons, some being that you have to crack the chest, put them on bypass. It's a very bloody, morbid operation with a high paralysis rate and stroke rates. And he was able to do it with a minimal incision. And you can listen to the back table talk that he gave about that. Now, what's even more interesting is, I think, and really where our evolution has occurred in the US is because of this gentleman, Barry Katzen. He established the clinical IR practice in Virginia, where he had consults, clinic, admitted patients, and did it the right way back then. And he was one of the early adapters of endovascular revolution, in fact, being one of the first people to do an EVAR, or endovascular aneurysm repair, in the US, renal angioplasty, TIPS, et cetera. He's a true visionary. And I encourage you to check out the ISET meeting in Miami every year, iset.org, and some of the cases they do. Interestingly enough, Katzen and Dake work together. I think that was pretty cool. So maybe they both got inspired by one another, but Dake certainly took that back to Stanford and was able to design the stent grafts. I'm lucky enough to work with this legend, Tom McNamara. The reason I came to LA is to train under his tutelage, because I knew I wanted to be a true physician clinician. He did his own wound care. He saw 30 patients in the office a week, admitted his own patients. And really that was established, that kind of model is what I use for every service on establishing the VISTA practice. Again, a clinical visionary in the field of interventional. And I do think this quote is something you should be cognizant of. If you haven't heard it, you're going to hear it over and over again. This is presented in the American College of Surgery in 1960 by Daughter. If my fellow angiographers prove unwilling or unable to accept or secure for their patients a clinical responsibility attendant on transluminal angioplasty, they will become high-priced plumbers, facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skill till others can learn. So heed that quote. And this is now occurring in BPH even, right? So any new thing, you can go to a blue ocean, but if you don't know the disease, you won't be there for long. I think there'll always be tension between IR and referring specialists. PA is just the latest example of this by a urologist. It has impressive solutions, but it will never understand the disease process to the degree of the referring specialty. And IR never sits in clinic with these patients. And so that myth has to be changed. And this is the elephant in the room. So if traditional IR practices here and globally don't adapt and change, they will die. It will be the dodo bird. And this is emulated by the Eamon Hobbs. I presented this in the chat yesterday, but this is the life cycle of VR that he described. And what it was is we're great at innovating, generated an idea, develop it, but then there's a certain lifespan where it starts to migrate out and there's lost procedures and minimal residual. And really it's because we don't own the disease. If you know the disease, the natural history of disease, the pharmacology, the physiology, the microbiology, and the kind of the alternative therapies, and counsel a patient in the office from a primary care or directly from a patient like they do in India, then I think you're going to have a chance. And to, historically it would go to primary care, then to a specialist, and then to us. Now it comes patient directly to us or patient primary care to us. And I think that's what we want to move from. Now, the challenges, I think, here and globally is what Aditi said is we are fishing from the wrong pond. If you have a bunch of people who really want to be a 9-to-5 job, read from home nowadays, not interact with patients, they don't enjoy patient care, and they don't like dealing with sick patients and emergencies and ICU conditions, this is a horrible field for them, but they don't recognize that. But that's a pond we've been historically fishing from. And these people will be unhappy because it's like an introvert in a crowd or an extrovert in an isolation. It just doesn't work for their personality. So what we need to do is really fish from our own pond. And that's why we're seeking out surgical types as opposed to kind of the diagnostic types. So again, we're focused on medical students who want to primarily own patient care, passionate about surgery and procedural medicine. And you need to have a stamina for the lifestyle demands of a busy VR practice. You can't run a marathon if you don't train, and you have to be ready to kind of run that kind of marathon. And for multiple decades, not for a decade, but 3-4 decades of existence. Knowledge of disease. Okay, so in radiology, we'll learn anatomy and pathology. No more efficient way to learn anatomy and pathology from head to toe, no question. But what you're lacking is physiology. You don't know how to interpret right heart pressures. You don't know how to do an echo, as was said yesterday by Dr. Desai at his keynote lecture. PFTs, ABGs, EKGs, you lose sight of all of that. Pharmacology, I bet Indrajit is losing a lot of this knowledge. And Jay, as time goes on, perhaps you'll be losing this as well, which is sad because when it comes to patient care, these things are all so important. Pharmacology, diabetes, hypertension. This is what I see on a day-to-day basis: statin therapy, antiplatelets, anticoagulants. These are medications I'm prescribing as a clinician on a day-to-day basis. Appropriate antibiotic therapy, whether it be for diverticulitis or osteomyelitis of the foot. These are things that I have to now manage. So again, the most efficient way to learn anatomy and pathology head to toe is radiology, but in radiology, diagnostic radiology residency lacks your ability to do a physical exam. And in fact, you use that donut of truth too much and you lose your ability to exam. And, all joking aside, the exam is still vitally important because the pictures only tell you one piece of the picture, right? If the patient has acute limb ischemia and they have motor sensory deficit, that donut's not going to tell you that. It'll just give you anatomy and pathology. You have to do a good neuro exam. You have to do the niche. You have to take the history and figure out what's going on. The history will tell you 95% answer. admit your own patients, learn from it, manage your own patients, manage the diabetes and hypertension, and talk to your patients, spend time with them. That's what medicine's about, is guiding and counseling a patient. That's what I do, guidance counselor. So integrated VIR residency is really to embrace and enhance that critical clinical component of vascular interventional training. In order to do this, you have to have outpatient clinical longitudinal care, and you need to be involved in that from day one of your medical school training. You need an inpatient consult service where you feel comfortable dealing with sick patients and making that decision of should we, not could we. I think that's key, not the could we. That's opening up an image and looking at it without going and seeing the patient. Should we is when you go see the patient, go, you look sick, let's figure something else out. And then admitting your own patients to your own service to get more comfortable with the perioperative management of patients, as opposed to letting someone else learn the disease that you should really be owning and understanding and navigating. We're able to use countless amazing things. These are just a few of the patients I've treated in the last 5 years. And if I just show you last week's patients, it'd be the same thing. One of my first pedal loops, and Karthik and I did this together, and salvaged her from a BK and a 40-year-old to a transmetatarsal amp. And she's become the biggest proponent of stopping smoking cessation. So meaning she's fighting for the Berger Society to make sure people stop smoking. This is an angiovac device. We were able to remove a tremendous amount of clot from the human body. And this is one of my patients that I'm still following with my neurointerventional colleagues, who is cerebrovascular perfusion abnormality to the right, because all her vessels are coming from this left side. And she restenosis this. We're going to probably, maybe even shock her this time, try some new technology to get improved perfusion of brain so she doesn't get dizzy, lightheaded, or altered mental status. This is one of my patients that I saw in the ER who had a ruptured AAA, but he couldn't give him blood. So we were able to do this with a big sheath, the poic graft, and he's still my patient to this day, doing great. His diabetes is under better control, and he's alive, and obviously very grateful, as is his wife, who almost passed out while seeing him, dying in the ED. So how do you thrive in this environment? In the last few minutes, first 2 years of medical school, focus on your basic science years. Pharmacology is critical, micro is critical, anatomy is critical, pathology and physiology are all very important. During your pathophys years, heart, lung, liver, kidneys, cardiopulmonary, renal, GIGU, and neurology are all going to be important things for you to understand to be a good clinical interventionalist. You don't have the luxury of just doing urology and forgetting everything else. You have to know all these things to be a good Renaissance physician interventionalist. Consolidate your knowledge is step one, even though it doesn't necessarily matter. Try to study for it so you learn everything, from embryo and put it together. Do some VIR research during those early years. Start to get on some research projects and educational exhibits, and go to the meetings, ICET, SIR, GEST, WCVIR, SIO, etc. Third year medical school, general surgery is very, very important. See if you can handle the VIR lifestyle, get your anatomy and surgical techniques in the day-to-day existence. See if you get comfortable with that component. Internal medicine is also very important. Physical exam, history, heart, lung, liver, kidneys, again, get those organ systems down, including infectious disease. Obstetrics and gynecology, especially fibroids, tubular ovarian abscesses and cancers, and stroke neurology are all important. Try to do well so you can emulate that on your class rank wherever you are in your training. Fourth year has to be your first year of 7-year program of VIR training. Busy VIR sub-Is, get a letter, where you're not just doing catheter time and observership, but you're actually in the room doing the case or participating, getting your access down, getting catheter time down, maybe some microcatheter clinic and consults. You might as well, if you're there, you might as well learn. ICU, do another month of ICU. A surgical letter, like a vascular surgery or surgeon, some strong surgical letter on a sub-I, where you're acting as an intern. And then stroke neurology, surgery, sub-I, cardiology consults are also valuable. You want to crush your sub-I. So what does that mean? First in, last out, introduce yourself to everyone. Do not be that stranger. Learn from the techs. They know a lot. Read up on your patients so that if there's a question asked, you know it. Own the back table. Know how to prep and drape the patient and unprep the patient and help the team. Don't do an observership, okay? Make sure you are part of the team, writing the procedure notes, asking to do stuff, go to clinic, see your patients, do formal consults, and again, know your anatomy. They're going to ask you a celiac artery anatomy, liver segmental anatomy, lower extremity arterial anatomy. During your surgical internship, which is highly recommended, again, make sure you go to the clinic, go do consults, scrub in cases, and then learn the post-op care and complications. Look at a program that's going to give you a lot of OR time as well, okay, and some ICU time. Endovascular surgery, wound care management are things you want to get out of it. The current model of integrated is a little bit not enough IR. It's 3 months and 3 years. We've established a model where we do 2 months PGY2, 2 months PGY3 back to back, and 2 months PGY4 back to back. We include ICU, the PGY2 year and the PGY5 year, multiple months of ICU and neuro ICU and CCU. And so now you're comfortable with sick patients, and then monthly VIR call PGY2 and half a day of clinic throughout the 5 years. And I think that's important, where you get continuity knowledge. Clinic is vital to becoming a good doctor. And that's how you're going to be able to answer the patient's questions. You're going to be a good physician. So I think these are all important things that you want to kind of be cognizant of. Okay. And then we have, admit your patients, do a formal consult service and longitudinal follow-up. Make sure all the service lines are built. Don't just focus on oncology. Build the vascular, the neuro, the cancer, and the various cancer therapies. GIG reproductive, fibroids, lower urinary tract syndrome, infertility for male and female, pain, and palliative, as you heard yesterday, dialysis. These are all important service lines. So in summary, it's becoming a surgical type field with a surgical lifestyle. It's very busy given the scope and complexity of practice. And quite frankly, at some point, the old model of pure procedurals will be harder to justify, as it's going to be viewed as itinerant surgery and patient abandonment. We're going to continue to transform medicine rapidly. I hope you join up on the ride. And one of you in the audience will hopefully be the next Daughter, Katzen, Dake, Amplatz, Palmas, etc. Focus on, this is kind of the key summary, focus on step 1 and 2, your core knowledge in MS1 and 2, IR specific research, network to get that. There's a huge network on this audience that you can get. Email me if you have any questions. Local VR symposium, set up a VIREG or get involved in it, get some busy ways and letters. IR specific research, general surgery, IM, crush it your 3rd year. Step 1 and step 2, even though step 1 doesn't matter, still is important. Class rank, AOA is great. Set up a VIREG, symposia, busy ways with good letters, network. 4th year, study an hour anatomy daily and the rotations that I suggest, including busy IR ways. So in summary, this is a patient-centered care surgical field with a lot of emergence, bleeding, clotting, infection. As you've seen, we are the cowboys of medicine. It's technologically driven and minimally or least invasive and maximally effective. And it's certainly not surgery light. And finally, patients do fight very hard. So it is your responsibility to train and fight harder. Here's my email. Thank you.
Thank you very much, Dr. V, for that super informative talk. Definitely a lot of advice in there that I'll be using in the next few years in my training pathway to IR. Before we move on to the next session, are there any questions for Dr. V? Well, again, thank you very much. I'll pass it on to Brad.
Thanks, Hiro. So I'll introduce our next moderator, who is Helena Rockwell in MS3 at UCSD for the session Ethics and IR.
Thank you for that introduction. And so it is now my pleasure to introduce our next speaker and topic. So next we are going to hear from Dr. Eric Keller, who's going to be talking to us about ethics in IR. He is an incredibly innovative and insightful PGY4 resident in interventional and diagnostic radiology at Stanford. He also has a background in bioethics and medical anthropology. He's the founder of the Applied Ethics and IR Working Group and also serves as a junior board member of the Interventional Initiative. He's quickly becoming a leader in the field, and I'm really excited for you all to get to hear from him now. And so, Dr. Keller, if you're ready, you can go ahead and start.
Sounds good. Thank you, Helena. I really appreciate the introduction and opportunity to hang out with you all this morning. So we're going to be talking about applied ethics in interventional radiology. As noted, I'm an integrated IR resident at Stanford. And I just thought I'd start right off the bat, like why talk about this? Not like ethics is the hottest topic, frankly, in medical school, residency, etc. And just to try and sell you a little bit on the idea behind this, the reason why is because kind of analogous to what Dr. V was saying, ethical issues because of the clinical impact of interventional radiology are not uncommon in interventional radiology. So when we've done surveys of IRs across the country, the vast majority feel that ethical issues are a regular part of their day-to-day practice. This stuff comes up. And so it's important to be familiar with. Now, the majority of them feel pretty comfortable navigating it, but they also feel like they need more support. So I think that's because, we get an okay ethics training in medical school, so we can figure out our way through it, but there's not that many IR specific resources to really feel like we have that support. And I think that's because a lot of current approaches are kind of limited. So, for example, what's often taught in medical school is called principalism, right? We have these 4 inherent principles that come into conflict. But I've never heard in a fluoro suite or a reading room anyone be like, wait a second, everyone, what are the 2 principles coming in conflict here? And then use that to make a decision. Just not the way that we think. And so I think there's a better way to do it. And that's what I've been trying to do through this applied ethics initiative, is to think about especially specific approaches that are more applied and practical, because, the way that we're going to deal with issues and the specific issues in IR is probably going to be different to a degree than OB-GYN, trauma surgery, psychiatry, etc. So that's why ethics. So what I'm going to do is take 3 topics that come up a lot in IR and do it case-based, just to give you a flavor. So let's start with the case here, 59-year-old lady with cholangiocarcinoma, obstructive jaundice. So the jaundice or the bilirubin is so high, she can't get more chemo. RA has 2 biliary drains in place, right and left, now referred to you for yet a 3rd drain to try and drive down that bilirubin. And the reason why I use this example is because it's actually the most common perceived ethical issue in interventional radiology, are these requests for potentially inappropriate procedures, or what some people would call futility. And that specific example is one of the most common ones that came up when we interviewed IRs, is this idea for continuous biliary drains or G-tubes with severe dementia. And the reason why this is important, if you look at the data, is that if you look retrospectively, so truly futile care, that's like undebatable things that didn't add any value, about 12% of ICU admissions adds up to about $3 to $9 million per month across institutions. And it's actually directly correlated with burnout. So you can imagine that we like to think what we do helps people. So if you feel like what you're doing is all risk and no benefit, that burns you out. It makes you feel bad. It makes you feel like you're not contributing to that patient's care. And then finally, the reason why this has been a difficult topic is it's just difficult to define. It's hard to know because of the diversity and how people perceive what makes something worth it, or different risks, things like that. What is actually futile? So people have thrown around numbers like maybe less than a 1% chance is futile, but we're also limited by our limited ability to prognosticate, right? To really know when it's truly less than 1%. And maybe 1% is worth it in some people's minds. So that's what makes this kind of a nebulous issue for us to try and approach in interventional radiology. And so as a practical thing that we could do, one very well evidence-based approach to these requests is something called advanced care planning. So goals of care discussions is an example of advanced care planning. It's just a conversation with people, usually when they have some sort of serious condition or near the end of life, about their goals, values, and what they really want out of the end of their life. And study after study have shown that this reduces costs, anxiety, and improves satisfaction, both amongst patients and family members near the end of life. So then the natural question is then, how often do we do this in IR? So we looked at thousands of image-guided procedures actually retrospectively, and the answer is not that often, actually. So in inpatients, around a 1/3 of the time, if you look at inpatients procedures where image-guided procedures where patients died shortly afterwards, how often did they have any sort of goals of care discussion, even documented in the chart, not even the conversation? So about a 1/3 of the time for inpatients gets down into the single-digit percentiles in outpatients. So I would suggest that maybe a practical approach for us for dealing with this issue, and what goes through my mind at least, is that when you get that consult, ask yourself, is this a palliative procedure, or one that maybe has a low chance of achieving what that team is saying is the reported goals of care? And then if there hasn't been any sort of documented advanced care planning, it's probably worth asking for it, or doing it yourself, just having that conversation. And that then allows you to reevaluate and say, well, is my procedure really going to help this person? Is this going to empower them and help them achieve their goals of care? And I think that approach is a little more productive sometimes than just kind of going back and forth with the referring team, or feeling not empowered and just doing it, because sometimes some of the quotes we'd get is that, saying no or saying yes is a lot easier than saying no, so just doing the procedure. And then, there is palliative care and ethics consultation is needed, which we tend to also from that survey under use in interventional radiology. Okay, next issue. Let's look at a series of hypothetical tweets. This one hypothetically from a radiology resident after a call shift. Any guesses what this is? Someone had a little too much fun this weekend. Hashtag foreign body, hashtag a little too far. A couple of radiographs there. Let's say this one is from a 4th-year medical student during their away, selling your fan. First filter out Friday got a little dicey. Not a bad end result considering the effort to remove this thing after a hashtag vascular surgeon left it in there for 8 years, hashtag malpractice. Got a picture from the fluoro there with a timestamp, picture of the patient's neck. And so this brings up medical social media ethics, right? It's an awesome tool and it's not uncommon. So even back in 2014, 41% of all clinicians use medical social media professionally. And that number has only grown since then, I'm going to tell you. And it's awesome. It's a great place for a rapid exchange of ideas. We get to do great networking. It's great for community advocacy, education, particularly during the pandemic, right? There's been awesome educational initiatives that are still ongoing in the IR space, in the radiology space, et cetera. But the potential issue is a few things, right? I think the one that's most obvious that people think about is patient privacy, like HIPAA. But honestly, there's a lot more to it. And I think actually the more insidious issue is these things that we're not posting people's names or MRNs, but we're posting these sensational cases right after they occurred in small communities where it's probably identifiable and therefore a HIPAA violation, or even if it's not a HIPAA violation, you know, the law is kind of the ground floor of ethics. So there's also the idea of patient dignity, right? Where the way in which you post it, you're not posting it about the patient, it's more of a notch in your belt or a punchline. So all those things kind of raise these sticky issues that are worth having a conversation about. Now, there are other things too, right? Information accuracy, conflicts of interest. There's no like peer review for what we tweet, and then interprofessional respect. A lot of times turf wars can flare up on social media as well. All things to think about. And so I think a potential approach for this, definitely work in progress. This is a pretty new area of ethics. So what I do is this pause before you post. I think there's a lot of power in just stopping and kind of checking those boxes and saying, you know, is this something that I would want my clinician posting about me or a loved one? Is this potentially identifiable? And then, you know, later on, as you get out into practice, if you're regularly going to be posting pictures of patients to promote your practice or for education, probably worth just incorporating it into your routine of consent, giving people the option to opt out and say, you know how I'm going to make this anonymous as possible, but, you know, I do this to educate people or promote my practice or whatever. Is it okay if I post some pictures of the procedure today? And then finally, it might be worth us putting together guidelines. So a few different societies have, including the vascular surgeons, something to think about for us too. Okay, final issue to bring up. So 84-year-old lady with history of dementia presents for a gastrostomy tube. You're sent to get consent. Patient says, I don't want this procedure. The daughter's with her, who's the durable power of attorney, says she's confused, do the procedure. And so this is getting at consent. So consent's interesting to me in that we almost take it for granted in healthcare. It's so common and becomes so common that we feel like that it's not an opportunity for improvement, despite, you know, study after study showing that consent practices are actually really, really limited in healthcare, including IR. And so if you look at the data, about 1 out of 4 inpatients lack capacity, and we incorrectly assess that in about over half of them. When you ask patients if they received the information they needed to make an informed decision, we only hit that mark a little over half the time. And the reason why, a big driver of that is because a lot of people have low health literacy. So if you look at the US, about a third of US adults, and that number gets closer to 60% over 65. So this isn't just intermediate health literacy, but low health literacy. And then IR, because it's such a dynamic, fast-paced practice, there's a lot of variability. So it's hard to do improvement in this area. There's a lot of different areas where we have consent conversations, a lot of different people involved in that conversations that also can make it difficult to do well. And the reason why this is important, not only for letting people make an informed decision, but also because lack of communication around procedures is one of the most common sources of medical mistakes and malpractice claims. And so how do you make informed consent, informed choice? Some of this is going to be beyond us as individuals, cultures and workflows, but let's talk about us as individuals. And some of it's just education, right? I know we, again, take it for granted, but it's important to be able to differentiate between things like competency versus capacity, consent versus assent, selecting the appropriate surrogate decision maker. So for example, in that case, you know, each time that you interact with that person, you need to reassess their capacity. So just because someone has a history of dementia, schizophrenia, doesn't mean they automatically lack capacity. You need to make that assessment. And if they have capacity, then it doesn't matter that they have a durable power of attorney. That durable power of attorney is only there if they lack capacity and can't make that decision for themselves. And then another thing that I've been working on is this idea of patient decision aids. So handouts, videos that present balanced information at the average reading level for people to try and empower them with that information. And a lot of practices have informational stuff that they hand out, but studies that have reviewed those show that they tend to be over the average reading level and not really great on readability scores. So we practiced with some experts in this area to try and make these for interventional radiology, vetted by multiple IRs and focus groups of people from different educational backgrounds, not in healthcare. And that's one of the things I'm working on with the interventional initiative to hope to come out later this year publicly. And we also have done some trials of this. For example, down at UCSD, we randomized people to get them or not. And in addition to improving their understanding and satisfaction, they also felt that people listened to them more and answered more of their questions, despite there not really being a difference between those two groups. So I think a powerful way to potentially improve consent in interventional radiology if we can get better adoption of these kind of better patient decision aids. And just as a how I do it type of approach to consent is, do the introductions and then figure out who needs to be in the room. Do you need to get rid of someone? Like, that person that's making the decision gets to choose if they want to be alone or have their family member there, or do they need someone? Do they need to get someone on the phone? And then I love to ask, what's your understanding of what's going on? This actually works on multiple levels. One, it's a spot check of capacity and what they describe. If I need to dig into that a little bit more, health literacy check, and also just figuring out what they already know. So I'm not talking over their heads or talking under them too, right? So I don't want to come off condescending. So trying to do that spot check up front, and then I can launch into those risk, benefits, and alternatives, as well as a recommendation. So the ideal of consent isn't just whatever you want, it's also to provide a recommendation as the expert. And then I always end it with this emphasis to say, this is, just want to remind you, this is completely your right to choose, totally your right to change your mind. And if you need more time, that's okay too. So lots of ethical issues out there in interventional radiology. That's just a flavor of 3 of them. Happy to talk to anyone whenever about whatever. We have this multi-institutional working group going for the last 2 years, trying to raise the consciousness of ethics in interventional radiology and developing kind of an ethical language for the specialty. So love to hear from you all. Thank you for hanging out.
Thank you so much for that, Dr. Keller. We did start just a couple of minutes late, and so I just want to see if anyone has any questions from the audience. Let's see if there's anything in there. There was a lot of conversation going on at the same time.
I know there's a lot of chats. I look forward to reading through the chats, but it's a complex topic, so I was talking fast.
One person did ask, I think maybe just any general thoughts on research ethics in IR.
Oh yeah, it's a whole field, right? Very complex. So I think maybe the biggest issue for research ethics was we recently had an analysis come out about conflicts of interest related to that. It's just that IR, since we create a lot of the tools that we use, it creates a lot of conflicts, not only financial, but conflicts of interest are beyond financial. And so when we look at top-sided studies in interventional radiology, we often don't disclose a lot of relevant conflicts of interest. And that's really because, we as humans are just limited in evaluating our own biases. So it raises the question, is there a better way to do it? Is there a better way to help us manage our potential conflicts of interest? And having conflicts of interest itself isn't wrong, right? We all have conflicting interests in what we do in life. It's more of how do you protect against the potential bias? That's really the issue there. So if you Google, we actually have our research group, not only that paper, but also has a nice little letter to the editor that's a little digestible snippet of research ethics in interventional radiology, if you're interested. I can post it in the chat too after the question.
That would be helpful. All right, well, thank you very much. And for giving us some of your time on this weekend. And then with that, I think I'm going to hand it back over to Navjeet for some announcements about Angio Club yesterday.
Yeah, we had an excellent turnout, really great cases that were presented. So I just wanted to announce a couple of awards as per the moderating committee. So Sankrit Kapoor won the most educational case and Karen Rao won the most interesting case. I'll be sending a little small token of appreciation a little later today over email. Thank you all. And now I will hand it over to Subhash Goody, who's a MS3 at George Washington University, as well as Emily Sturbis, who's an integrated VIR resident at University of Colorado.
Awesome. Thank you for that introduction, Ajit. Hello, everyone, and welcome to the OBL/private practice session, which is actually the final session of our symposium this weekend. My name is Subhash Goody. I'm a third-year medical student at George Washington, and we also have Emily Sturbis here as well. Emily is a PGY3 at University of Colorado, who's helping organize a lot of these OBL webinars. She'll be moderating the chat. And today I'm joined by 4 very well-known, very well-established interventionalists. Each of these panelists has been quite successful working in the outpatient realm, either currently or in the past, and they have a lot of expertise to share with us today. So I'm so thrilled that we could bring you all here together for this session today, so that we can learn more about this new frontier in our specialty. And especially because this is a topic that it's very important professionally, but we don't learn much about at all during training. So as we know, IR spans many different service lines and covers many different disease processes, and each of our speakers brings a different element to this discussion today. Here we have Dr. Srini Tumala, who is an expert in PAD. He worked in the private outpatient setting before being recruited by the University of Miami to kickstart their VIR program. We also have Dr. Mary Costantino, who is very well known in the IR community and beyond for her work on fibroids and women's health, as well as vascular disease. And she's director of Advanced Vascular Centers in Portland, Oregon. We also have Dr. Justin Lee, who is unique on this panel for his expertise in interventional oncology. He's running some important clinical trials on oncology and therapeutics. He's currently the regional medical director for Radiology Associates of Florida. And finally, we have Dr. Goke Akinwande with us today, who performs the full spread of IR interventions, and he's currently director of the Midwest Institute for Non-Surgical Therapy in St. Louis. So to our audience, this is an amazing opportunity to see the full breadth of what IR can do outside of the hospital setting. And with that, I would love to just hand this off to our speakers now. They can give you a more detailed introduction about their journey to the OBL world and about their current practice. So speakers, if you want to take 4 to 5 minutes each to just kind of tell your story, we can start with Dr. Akinwande, if you don't mind.
Do you hear me pretty good?
Yeah, we can hear you.
Okay. You guys can see me or no?
Yeah, we can see you as well.
Okay. All right. Okay. So I'm Dr. Akinwande. To give you a little background, I started this about my practice around 3 years ago. Initially, after fellowship, I moved out to St. Louis and I started academic practice. At that time, I had about 85% clinical and about 15% research. I had a grant for protected time, and I did it for a couple years. And you know, I had a different mission in my mind. And thanks, Georgie. I'm sorry, I'm distracted by the text, but so I had a different mission in my mind, and I felt that you know, my contribution to the world should be clinical. There were other reasons, obviously, but even though I enjoyed my research time, I felt that my mission was to provide my services and, you know, create more access to what we do, to be able to educate the community about what we do, to do it at a community level. True story. I started marketing when I was at Barnes, and I remember kind of coming back and talking to some of the nurses there and trying to schedule a patient that you know, was just kind of like a PAD referral. And I remember them just kind of saying, well, the patient doesn't have any CTA. There's no CTA MRA. And I was like, well, there's no ABI. And I said, that's what I'm here for. I will order that. And so I know that there was definitely a disconnect between academic medicine and community-based medicine. So I took the plunge and I started this practice in 2019. And we can go more into it and kind of like how you would approach starting a practice. But I started in 2019 and we've never looked back. We grew every year, and now I kind of own this practice called Midwest Institute for Non-Surgical Therapy. So.
Awesome. Thank you, Dr. Akawande. And we could go to Dr. Mary Costantino next.
Sorry, I'm laughing at Justin's headphones. Justin and I did fellowship together, so it's awesome to be back with hanging out with him. Yes, I went to Georgetown. I'm kind of actually a little bit of an academically oriented person, but I didn't really find my academic place. I love research, and at Georgetown, I loved working with Spies and Justin, and just thinking academically about things. But when I came back to Portland, I was in private practice. That was right after fellowship. And then after 2 years in a traditional setting, what happened? I was working all the time, and I just decided I was going to do UFEs, and an outpatient diagnostic group wanted me to do biopsies for them, which I thought was like kind of lame. But I really was unhappy at my practice. I was like all the time, working all the time and on call all the time. And I had 2 little kids, and I was not doing great cases. And finally I was just like, it just blew up. I was like, I'm done with this. And I walked out the door, and then, and it was kind of crazy, but I did that. And then for the last 10 years, I've been in outpatient IR. So I used to take all my cases. I built my own practice, and I used to take all my cases to the hospital. And then after way too many years, I realized that I got paid, like $200 to do a case or $300 to do a case, and the hospital was billing $40,000 to do that case. And, I knew this, and it took me way too long to move away from that. But I finally did. And I opened an OBL, and that's where I live right now. So it is interesting, running this private practice section for SIR. There's really a lot of similarities, I would say, between all types of IRs. So we have to just remember that we're all more alike than we are different, but our days and our challenges are different depending on your practice model. So I spent a lot of time in the business world, and a lot, I don't really love, I would say 30% of that, but I have to do it. So I would say there is an element of grass is always greener. And I would say that there's challenges in every type of practice, but I love what I do. I've got complete flexibility. I'm my own boss. If I don't like something, I change it very quickly. So works for me.
Awesome. Thank you so much for sharing. Dr. Srini Tumala, you want to go next?
Hi, sorry I was muted. It's good to see Mary and everybody here. I haven't seen you guys in a while. Glad to be here. Appreciate the invitation. I would dare say I'm probably the oldest one here, unfortunately. So I did my fellowship back in '99 and at Miami Vascular Institute, and then stayed on as an attending for a year, and then went into a private practice, which is really a tertiary care private practice in Atlanta. For about 7 years or so, and then ended up going to UCLA, did a neuro stroke fellowship, went back into private practice again, worked at a practice that owned a lot of equipment and an outpatient center and so forth. And then about 6 years ago was asked to come to the University of Miami to really start a CLI program, because they were really not doing anything at that point. And I think for about a good 20 years, they weren't doing much. And so although I'm in the university setting now, we do have an outpatient center that functions like an OBL in the sense of billing and coding and inventory and so forth. Now we have a pretty robust peripheral arterial disease practice. And so I kind of had a very, a long kind of course to get to where I'm at. And most of my referrals where I'm working now are actually not from within the university center, because my referral base is really from a lot of the private doctors out in the community. And, I'm in South Florida, so it's a 3-county, region. And I'm sure, like Justin and Mary and everybody else, it's a constant battle in terms of practice building. And, even if you think you've got, a referring physician who's sending to you consistently, that could change at any time. And you constantly have to, be in communication with them, not only to tell them kind of what's going on with their patients, but just to see how things are going. Are they having any problems in terms of referring patients to you, getting a hold of you? They want it as seamless and as streamlined as possible. When they call you or text you or email you or send you whatever message they're going to send, they want it as, they want it really, and I'm sure Justin and Mary and everybody can speak to this. They want it, I'll take care of it. It's done. And the rest of it is in your hands, from the calling the patient to scheduling to discussing everything with them, getting them into the office, coming up with a treatment strategy, treatment plan, and then obviously getting them back to the referring doc. And, I'm sure, the others will tell you the same thing, is that when you're starting a new referral stream, you have to have everything as perfect as possible, because, all it takes is that patient to go back to the referring doc and say, I didn't like the process. I didn't like the experience. And it could be as simple as they didn't like the way somebody answered the phone. They didn't like the way a nurse talked to them when they were in the, pre area or the post area, or they didn't get crackers, they didn't get a sandwich, they didn't get something. It's not always about, hey, I did a great job from a treatment and physician standpoint. You have to understand all these processes that are taking place have to be perfect while you're building that confidence in that referral stream.
Thanks, Dr. Tamala. You made a lot of great points. And for our audience, Dr. Tamala has a lot of really great educational tools. He has his own YouTube channel. Take a look in the chat for the links to those YouTube videos. And finally, we
add something on what was just said.
Sure.
I had a patient once who complained the entire time about how the drape was on her face during a port. And I'm like, lady, I got you in here the next day, put a port in, you had no pain, it was smooth, it was like a 17-minute procedure. I brought her crackers, water, and she's like, I just can't, and the drape was like up, but it just felt a little claustrophobic to her. And I'm like, I just performed basically a surgery on you and you didn't flinch. And the drape is your big complaint. And you have to be like, I'm so sorry. I totally understand. It's crazy. And we all have lots of those stories, and it's pretty incredible. Because if you're good and you're doing the right thing, then when their complaints are like, the drape was just a little too close to my face, it means you're actually doing a good job at all the other stuff. But you got to absorb it and handle it.
Exactly. Yeah. Clinical expertise and patient experience can be two different things, but yeah, mastering both is key. And finally, we have Dr. Justin Lee here. Dr. Lee, you want to go next?
Yeah, of course, Mary would want to steal some of my thunder, huh? Yeah, and Srini, you are the oldest one here. Oh, really?
During residency, he would always I would always have to tell him the answer, and then I would get in trouble.
Mary had like a actual clinical thyroiditis during our fellowship, and we all just thought that was her personality, but actually, her thyroid hormone level was like
I had a goiter.
5,000. Yeah, so
I had a goiter out to here.
Well, unfortunately for a lot of people who are on this call, I represent what the side of radiology that I would be willing to say at least 75% of you will have to contend with. So about 5 years ago, my practice was bought by Radiology Partners, which is a private equity group. And, and we can talk a little bit more about that, but I work for 170 radiologist radiology group that is part of a nationally owned, private equity owned radiology group. But within the little pod that I work in, which is down in Sarasota, Florida, for a 1,000-bed hospital, we have 9 interventional radiologists, and we've built quite a clinical practice for ourselves. But I think the great thing about everybody here is that we have this this story of how your practice is going to change. And I think just about everybody on here has a similar thing. I mean, my first job was in academic practice for 4 years, and then I left and kind of started for a traditional private group that had a partnership track. And then that group got consumed by one of the larger, private equity groups, which we can get into some of the details of what that actually means. But, the journey that everybody has is what really crafts how you approach your own clinical practice. So for me, I think like my opinions of what I was going to be as an interventional radiologist when I was in training is completely different than the realities that I face day to day in terms of managing things like turnaround times and making sure client hospitals are satisfied. And then on top of that, making sure that my practice is professionally satisfying and that I'm getting paid what I think is a fair wage for what it is that I do. And that's not always like a linear path. That's got a lot of different bumps and turns to it. In fact, we're going through some of those right now as it pertains to outpatient and costs associated with in-hospital versus out-of-hospital care, and how to bridge that when, the overarching group may not have any knowledge about how that could provide value. And then even worse, how the hospital system can view that as being a competitive and, competitive business to theirs. So, at this point now, because I'm the medical director, I'm dealing with things like, how you interface with diagnostic radiology and how you provide not only clinical value, which to everybody who's meeting clinical values, one of those things is kind of obvious, like go see the patient, establish a clinic, and all those wonderful things. But on a financial side, those don't really work. And, when it comes down to it, you have to be understanding of all that stuff. And then lastly, I think, for me, when I would go to ISET, I wondered like how these private guys were, having research and this seemingly, professional interest in what they were doing, but they were also, earning salaries that were very competitive. And, I've been able to do that, but that takes work that you got to do. It's why you would do a panel or a meeting or something like this for free. You just got to do that on your own. And I think that is something that everybody's going to have to dig down. Everybody who's on this call probably has an interest in doing stuff outside of normal work hours. And that's, I think, one of the biggest challenges that we find when we go to hire people is the understanding that a lot of the things that you may want to do, you're going to have to do on your own, and you're not going to get paid for it. And you do it because it's the right thing to do. And it's because you want to do it and have that professional interest. So.
Awesome. Thank you. Yeah. So we've heard a lot of different experiences and challenges and pathways kind of to your current practice setup. And we also heard how different one IR practice can be from the next. And to our audience, the remaining time in the session, it's intended to be kind of semi-structured. If you have any questions, please drop them in the chat. We'll try to pick them up. But we'll go ahead and get started with some questions. So going back sort of to the beginning of your journey, I'm interested in hearing, like, what were the main factors in attracting you to the OBL setting? We heard a little bit from Dr. Costantino on why she made that switch, but yeah, what was the motivation, given that there are so many challenges and risks with making that transition? And additionally, what is something that you wish you knew as you were beginning that journey?
I mean, I can talk about past experiences with an OBL and what it's like. And obviously Mary has, tons and tons of experience. And I think what everybody has to realize, because we don't want to make this sound gloom and doom, but I think IR is a great specialty. I think we have a lot of positives and a lot of growth potential. And, IR is moving outpatient really over the next 10 years, let's face it. But with that being said, if you're going to go into this OBL or ASC, the ambulatory surgery center space, whichever you're going to choose, whatever you're going to do, whether it's starting your own, joining an existing one, or joining, a multi-specialty practice with physicians from other specialties that are either your partners or equity owners, et cetera. is that it is a business. It is a business that you're going to be working 100% all the time. It's a 24/7 job. You know, it's not like, oh, I need an ultrasound. All right, well, which ultrasound, which company, which price? I need IVs, I need gauze, I need tape. And obviously now, you know, it's much easier than 20 years ago if you tried to do this. Like some others have done, is that there are companies out there, whether it's Philips, you know, Boston Scientific, Siemens, et cetera, and Mary can speak to this as well, is that will help you do these things, but that also comes with a price. They're not cheap. And they're not going to make it, you know, at the end of the day, they're out to make money, you know, and there's consultants and consulting companies that'll do this as well. And again, the problem with them is they charge an arm and a leg. And so I think, you know, the OBL space sounds glamorous, it sounds sexy, and I think it can be. And I think Mary has shown, you know, what success looks like. But I'm sure when Mary starts telling you about this, that came at a lot of effort, a lot of learning. You know, it's like starting, a bakery down the street. You have to know everything from A to Z. And, you know, right now, if you join an existing radiology practice, a lot of stuff's done for you. You don't have to worry about the supplies, the inventory too much. You can start things. You have a lot of resources available from even who's going to answer the phone at the front desk. How are you going to do pre-certs? And, you know, and then on top of it for IRs, and Mary can probably speak to this, but in South Florida, if you want to get insurance contracts, and in Justin's, you know, a little north of me, but at least in South Florida in the Tri-County area, you can go to an insurance company and they will tell you that we have too many IRs that are on our insurance contracts right now. So we don't want to give it to you right now. And that can take anywhere from minimum of 1 to maybe 3 years. And it's a difficult process. So the point I'm making is, this is not something you want to take lightly, but there are tons of positives when you are successful in this venture.
Well said. I mean, I kind of want to chime in on this. I mean, the first thing I want to tell everyone is definitely don't do this for money. I mean, you know, anyone that asks me, I'm always consistent in telling and saying this. Do not do this for money. You should have a mission. So typically I would say to people, you're doing this because you want autonomy, or you're doing it for a specific mission. So let's say you want to decrease amputations around, you know, Missouri or you know, California. You want to bridge the gap in health disparities, et cetera. You want to educate, have a mission. And because if you fail, then at least you try to accomplish your mission. And maybe it wasn't financially rewarding, but at least you did something good for yourself. I definitely stress that a lot. Then also, like a lot of people that, you know, do this kind of thing, they're trying to create something of value. And, you know, believe it or not, when you create an OBL, if you're successful, it is something of value. And some people just thrive in it. I remember even building the practice was more fun for me than now where I am, which is kind of like it's built, and I'm always kind of looking for that thrill. And then you try to find other opportunities, and now you're searching for that thrill on the rise. I remember I was a lot more motivated to go to 100 practices to go market when I first started. Now I'm like, you know, it'd be nice to go home, take a nap and chill with my kids. So yeah, so, you know, there are a lot of challenges. You asked that question, is like, what do you wish you knew? I would say that when I started, I understood why a lot of people don't do it. So it's not easy. You get boxed out. You know, it's hard to be a doctor when you're worrying about like supply chain and human resources and, you know, pre-op, you know, stuff like that. It's hard to be a doctor. Sometimes you hire people. Like right now, we deal with a lot of human resources issues ever since COVID. People, my MAs make like $20 an hour. That's the only way to recruit them. So that increases your overhead. You know, so it's a whole bunch of problems. I did a national search for a manager to manage the practice, and she was completely terrible. Had to fire her in 2 months. And then now I'm back to managing it by myself. So there are a lot of challenges. It's not all glamorous. It's also, you know, one of the biggest limits or limitations to an IR building a practice, and I'll tell you this, is it has to be consolidation of medicine, and also the fact that you can't get hospital privileges where you want to. It really is a limitation. So you really have to kind of find your space and do research and figure out if it's possible to do it wherever you are. But yeah, I'm open to questions. I mean, I think, you know, this is a great conversation to have. You can definitely be successful at it, but you have to thread lightly, and it's not all glamorous. Yes, I agree with you.
Can I comment here? I'm looking at some of the comments. So I don't work in an OBL, but I go back to my first statement. I guarantee that more than 95% of you will join a practice that's more like mine. Well, or you'll be working for a group. And I think that's probably a good first step, because actually the first case I ever did was in an OBL. I was waiting for my license to come through so I could work at Georgetown, and I covered an OBL. And the first thing I did was try to mature a fistula that a surgeon had created, and I ruptured it, and his arm blew up and was like, was huge. And there I was, like in a shopping mall, basically like, holy crap, you know, they don't have, you know, covered stents and all that other stuff. So you're probably going to join a practice that's like mine. But I don't think that it should all be doom and gloom. There's a guy here who said, you know, you should look at CMS website and understand things about reimbursement. So one of the things to get is that the way that physicians get paid is on a system that's based on work units, or RVUs. And RVUs have a certain monetary value to them. And then the RVUs get assigned for certain things. So for example, I just happen to know these, but like putting in a Metaport is 6 RVUs. Reading a chest x-ray is 0.18 RVUs, and reading a CT is about 1.5 RVUs. And what's interesting about it is that, you know, when you look at how practices are arranged, there is the RVU value that directly goes to your practice, which, you know, for a busy private practice that's earning salaries, you know, $400,000, $500,000, $600,000 a year, you would expect each one of your radiologists to earn 15,000 to 20,000 RVUs a year, which as an IR is really difficult to do. Because if you see a patient in clinic, or you see them up on the floor and then you bring them down, you do an embolization procedure, that could be like 10 to 20 RVUs, but the amount of time that you put in to do that, you know, could be 2-3 hours. So if you can only really register 20 RVUs for 3 hours of your day, which actually that's probably pretty good, but your diagnostic colleagues who are just sitting there could do 10 RVUs in an hour. A really good diagnostic radiologist can tick off more than that. But then there's the concept of like value beyond, you know, what CMS tells you, which is where interventionalists do provide a lot of value to a DR group. So for example, we do stroke and trauma. The reimbursement for a stroke embolectomy is about $800, which is pretty low. But the hospital gets like $50,000 for a stroke activation. So we consistently end up negotiating on these things that we provide to a hospital system versus what we actually get paid. And this is where kind of the rubber meets the road in terms of trying to convince your DR colleagues or the hospital of the value that you are providing above and beyond simply, you know, how many RVUs you generate, and you know what you generate for the hospital. And this is probably going to be the most common practice model that everybody fresh out of training joins. The problem that I see is that I was a Surtex proctor, so I got a chance to go around and meet a lot of people who are new in practice or trying to get their Y90 programs up and going, and they'd always ask the question like, well, but how do I do better cases and, you know, whatnot? And if you understand that sometimes the better cases, they don't match in terms of the RVUs, a lot of that work that you do to get those better cases and to do them really requires work that you're going to do outside of what a typical day might be. So You know, for me, for example, I just started this prostate artery embolization practice, and it's basically almost all that I do right now. And I've given away a lot of the IO and whatnot to some of my junior partners. But that took a decade to get going. And on top of that, that's within a hospital. So the value I had was that I was making I get a paycheck every 2 weeks. All my overhead is covered. I have health insurance. I have a 401k, all that type of stuff. But a large majority of what had to happen there was work that had to be done, just like, these guys did to get their OBLs going. You want to get a PAE practice done, and you've got 20 urologists in your community who could care less, and the AUA is telling them that this is an experimental procedure. And then on top of that, you're a financial threat to them. You've got to really do a whole lot of work to learn about IPSS scores, learn about where PAE could fit in terms of sequencing. Could you do a PAE prior to a resume or whatever, an aquablation? All these different things. And that happens outside of, the 8 to 5. And that's stuff that you've got to do in addition to, for me, last Thursday night, I did 3 traumas in the middle of the night, didn't sleep. In our group, we get our post-call days off. Well, my post-call day is not, sleeping in and, going to have a coffee at Starbucks or whatever. Maybe it is. I do have a coffee at Starbucks, but that's where I'm like scheming to get all the other things to fall into line. That's where I'm following up with patients and really pushing forth the clinical side of our practice. I just met with a practice who was trying to figure out like why they would want to have nurse practitioners, because a nurse practitioner is a line item expense to the DR group. Well, you've got to figure out how to do basically things like net present value of what, okay, you pay a nurse practitioner $100,000 in salary, $150,000 with fringe. Well, what do you get back in that? How do you make that balance out? And I think it's definitely possible to do in the more traditional practice, but it takes a lot of work, the same amount of work that these guys are going to talk about in terms of marketing and figuring out finances and contracts, all that other stuff. Well, if you think that you're not going to have that because you join a big group, then you're sadly mistaken. You're going to spend a lot of time trying to figure out how you can achieve the destiny that you want, which is that you're doing the good cases, the things that you think provide a lot of value to patients. You're not just doing paras and thoras. And nobody's going to serve that up to you on a platter at all. Not to be negative about it. It's possible to do. I do all this stuff, research, industry. I try to follow in this sort of Barry Katzen-esque model. And I'm sure Goji could chime in here and let us know, because he's done it within Kaiser, if that's where you still work. I'm not quite sure. But, it just takes a lot of work and a lot of effort. And I think, unfortunately, the road doesn't stop. The race doesn't stop once you finish fellowship. In fact, it gets harder, which is not what you want to hear either, but that's the truth. I don't want to talk too much. Mary will get mad at me.
Mr. Bosch, I think, Mary, do you want to say something? I don't want to talk. I think Mary has
what to say. Yeah, so, well, the first thing is, for sure, when you're in training, this is all stuff. I'm almost 50 years old. Justin's old. We're like, everybody here's old, except for Goke. 45. So it's like so sweet. So we've had years of being IRs and doctors. So definitely, this stuff was not at all talked about when we were in training. We didn't even talk about an ICD-10 code. I think actually we had to code our studies, but we always thought that was annoying and didn't really understand what it meant. So, really when you're younger, just really, really, really focus on being super good at your job. I've had every type of scenario. I do in the PAD cases, these guys all have COPD and they have renal failure, and they just have every situation you can imagine. And I have to be able to treat these guys in outpatient. So I'm pretty comfortable with my medical skills. And so far, so good. But I would really focus on medicine. in the training. And for the first couple of years after your fellowship, just try to work in a really high volume practice so that you can fly alone. It's it's very intimidating the first year that you're out on your own. And what I do see, I see a lot of younger people who want to go into OBLs, but they rely a lot on their partners. And so, you're not OBL ready if you're in a group and you're kind of always needing the next guy to come in and help you. Having said that, I think that's a balance, because you don't want to be a cowboy, and if you need help, you should call for it. And I certainly still do. I mean, I'll call people, when I'm kind of stuck of what do I want to do here? I don't think there's anything bad or shameful about reaching out and talking through a case with a partner or somebody you trust, but you've got to be really able to fly on your own. And I would say that's year 3, 4, at least after a fellowship. So you have plenty of time to learn the business stuff. When you own, I own an OBL, and I'm basically a CEO of a multi-million-dollar company, and I don't even know how that happened, but I learned a lot of hard lessons, a lot of hard ways. And when you learn everything, let's say about coding, it changes. So all of these things are constantly changing. So the pre-authorization process is super complicated, and it's just getting worse and worse and worse and worse. And so what you do is you hire all these people, and the next thing you know, you're spending all your money hiring all these people. And then you're like, well, why am I even doing this? So there are cajillions of people making a lot of money off of healthcare. So you got to control that too. So some things are worth it and some things not. It's just like hiring people to help you in your house. If you have a house cleaner and a nanny and a gardener, and at some point, all you're doing is going to work to pay for the bills for the people to clean your house, you might as well be at home. So you got to kind of keep an eye on these things. Like I have challenges now. I've got a guy who wants to do cases in my lab, and I have to figure out how to pay him fairly. Like that's a complicated algorithm. And if you work for a rad partners, like Justin doesn't have to do that because, well, he may as medical director, but chances are they've designed that, they've carved that stick a million times. I haven't. So I have to, and that means, I was up at 5 a.m. this morning, going back through my collections and numbers and trying to figure out what would be fair to this other person. And then I'm going to have to deal with the credentialing and just everything around it. So it's a huge amount of work to get this guy up and going. So this is a new, so when you own these things, it's always a new challenge, and it is a lot of work. I kind of love it, but the medicine part for me, like the cases and whatnot, I barely even think about it. Like I do a UFI in like 25 minutes and I've moved along. I can't even, but like 20 minutes after I'm done, I can't even remember I did it because I'm coming back the emails and all sorts of things. That is a challenge. And so as you rise up in leadership, it does become my challenge is how do I compartmentalize the medicine and the leadership and all the other jobs I do? You're not going to have this issue early on, but just know that it looks kind of glamorous from the outside, but I work every single day. I'm waking up in the middle of the night at 3 a.m. because I had some idea I needed to check on something. It's so, but I like it. And the medicine part, the IR part, I love what I do. I love entirely what I do. And I'll be honest, a lot of what I went into this for was some flexibility. I don't ever have anybody tell me when and how to take vacation. And, like I have a son who's now playing varsity football, and next year, I think I want to take every Friday afternoon off to do the football team dinners. And that's not a stress. I'm going to do it. Like nobody's going to say no. And I can decide the Thursday before if I want to do it. And for me, that works. It's worth getting up at 5 a.m. because I have complete flexibility. I raise kids, and I do a lot of board work in town. I do a lot of other things. So it's, for me, it is very worth it for the flexibility. I'm kind of rambling. I don't feel like I'm answering a question right now.
I think, okay, go ahead.
Oh, sorry.
So,
yeah.
Oh yeah, go ahead.
Oh, thanks, Goki. Subhash, I think one thing that was very important that was said by, I think, Justin or someone else, is that it takes really 3 to 5 years after you're done with your training to start feeling comfortable with what you're doing in your specialty.
I think I said that, and you just give credit. See, this is what happened in fellowship all the time.
Mary said it.
It just happened again.
Hey, Justin, Mary said it.
I didn't say a damn thing, so
I vote for Mary.
she blames me.
So let me start over then. So Mary said, that in general, it takes about 3 to 5 years. The bottom line is this: you really have to be good at your specialty and what you do to where it's almost, it's like the back of your hand, right? It's very automatic, most of the stuff. You understand when you look at a patient, this patient looks too sick to treat here, or something is going downhill, or I need to stop, et cetera, et cetera. Because I think when you're in the OBL setting, you're pretty much alone most of the time, unless you're lucky enough to have a bunch of partners and colleagues. And if you think you're going to be treating all the simple patients that have no comorbidities or any other issues, I think you don't have a good idea of what you're really going to be getting yourself into. So I think, we have we have a lot of IR residents in our program, almost 20 total, I think, for 4 years. And they all want to do OBLs. They all want to go into OBLs, but having trained them and watched them over the 4 or 5 year period they're with us, I tell them all the same thing, that you're looking at version 35 of me. I learned from a lot of mentors at jobs, standard radiology practices, how to do basic things: an HSG, a discogram, an upper GI. I mean, I used to sit in an MR center and read, 60 neuro MRs and, rule out appendicitis in a OB patient in an MR. So the point is that I have a lot of experience that I gained from working. And I think with that is what gives you more comfort when you finally get out and want to venture out in this thing. Now, other people have a very high risk tolerance compared to me, and they're more willing to kind of say, you know what, I'm going to go and do it. And, if you're able to do that and you think you have that personality style, go for it. But I would try to become as educated and talk to all these people on the panel. You can talk to Kavi, who's on here as well. He's an expert in the OBL space. Bill Julian, Curtis Anderson, Brooke Spencer. There's so many people you can talk to in this space who are nice and are willing to talk to you about this kind of stuff. That I just think you just want to know what you're getting yourself into. And the other thing too is learn how to practice build. I will tell you, we did a SIR webinar a couple of years ago. And the one thing we're realizing about our trainees and our people that are coming out is that they don't know how to practice build because we don't spend time talking about it. If you talk to a gynecologist or a family practice doc or any other specialty, what are you going to do when you're finished? They pretty much say the same thing. I'm going to get business cards. I'm going to get an office. I'm going to get somebody to answer the phone. I'm going to get somebody to do pre-authorizations. I'm going to work on inventory, this, that. You talk to a lot of our IR fellows, and I think they're pretty well educated in this space because I torture them on a daily basis. But even them, a lot of them will say, oh, I'm going to join a radiology practice and see what comes my way. And that's great. I think you got to find the niche that works for you and what you're happy with. But like Justin said, if you want to do high-end IR and high-end big cases, whether that's oncology all the way to PAD, UFES, PAE, et cetera, you have to practice build, and that's going to be off hours. Nobody's going to let you go. Your DR partners are not going to say, go take 2-3 hours, in the middle of the day and go practice build when they're slaving away reading, 300 studies during the day, and they already may feel like you're not doing enough work from an RVU standpoint. So there's a lot of things to think about here before you just jump into this OBL space.
I want to just comment a little bit on some of these things that are coming up in here about non-competes. So when I got out and I signed my first contract, I did not have a non-compete. As I was leaving, and this is an academic center. So as I was leaving Georgetown, they had a non-compete set up that was every county that bordered on Washington, D.C., which is huge. And I currently have a non-compete that is 4 counties wide. And for anyone who doesn't know what a non-compete is, it's basically this paragraph in your contract that says that if you terminate your employment for whatever reason, you can't practice within a certain geographic area for a certain amount of time. So my non-compete is 4 counties for 2 years. And that's like That's huge. That's a real hurdle. I mean, it's something that I could not even imagine when I was a trainee that somebody would say my ability to work as a physician would be prevented by a group of lawyers. And at the moment right now, someone had put in there, but being on the side that I'm on right now, I can't imagine a medical group that wouldn't have a non-compete. And including the people who are on this panel who have OBLs. Like if Mary, brought you in and you got a chance to spend time with her and figure out how all this stuff goes, and then you pull the ripcord and decide you're going to open up a practice right across from her, like, number one, that's not cool. And you might think you're doing it with the best intentions, but, Mary's got to keep Reichler and all these people fed, right?
So I will come after you.
Yeah. So
just beware.
So the thing is that this is sort of the reality of the business. And I did hire an attorney and I went through it. And I've had attorneys when I've looked at my non-compete basically say like, well, obviously it's all local, but what will occur is that they will look at the non-compete because most states have legislation. This was built to protect small business people like Mary, from opening up and then having somebody come and essentially steal a lot of her sweat equity and directly compete with her, or potentially even take patients that are hers and do them. So it was actually done as a business protection thing. It's metamorphosized to this this thing where it can feel very much to be not fair, particularly like imagine one of my radiologists. I have 170 radiologists in my group. And you're going to tell some diagnostic radiologist who sits in a dark room all day that they can't then go do radiology. Now, technology helps a lot of that out, but as more and more consolidation occurs, that can become trickier and trickier and trickier. But anyway, the attorneys will look at these and they'll say, okay, well, on the face value, is this something that is justifiable and fair, or is it too overburdening? And in the state of Florida, which is a right to work state, I've had my non-compete looked at, and it's pretty solid. And basically, the statement that the attorney will give you after you spend a couple $1,000s to have somebody tell you about it will say, well, it's really up to a judge. It's up to a judge to kind of make a decision as to whether or not this is enforceable or not. And unfortunately, if you go Google any of this and look at case law, most often it doesn't side on the side of a physician unless you can prove a couple certain things, which I won't get into. But going back to it, I couldn't imagine at where I'm at right now, having not had the decade of experience in the field of medicine. And Mary's making it out like she just did this. I know this from a fact, like she did the whole big group stuff and cut her teeth on cases and still takes call at OHSU or whatever the hell it's called. And, got all these things to the point where, yeah, everybody on this call right now, the medical part, like I don't get bent out of shape about getting called for, crazy trauma in the middle of the night. It's just like, I get more pissed than I'm being called, but when I first started, I mean, I can remember, back doing like the first tips that I ever had to do. And I was surrounded by great people, Jim Spees, Phil Banovac, like all these people that were there to like support those first couple of cases. Yeah, well, you left and I was still there. So the thing is that like, I think, to be honest with you, and I've read some people on here talking about like going and do an OBL. I think that'd be great, but you got to be worried about the fact that you're going to probably have to. I mean, I think you're talking at least $1 million to $2 million to get a really good OBL. I mean, we have an OBL, like we call it an OBL within our thing. It's got this C-arm on it, and I'm still at the point where I'm thinking to myself, like, would I want to do a PAE here? And, I know that there's a lot of speakers on here, or I looked at the list of people who are doing PAEs in an OBL, but to do a PAE and you're in your university flat panel, cone beam, all this other stuff, than to do it on a GE field of view that's, you know, like whatever. It's a huge leap. And I think that there's another thing I wanted to talk about that Mary had said, like, oh, being able to build out your, you know, like your lifestyle. I mean, I get 8 weeks of vacation plus every post-call day off. You know, if I want to have time off, I can do that. You can build that in your own group, but it takes time. All that stuff takes time. You know, one of the challenges we have is we have people that come, and I look at applications like constantly. And when you look at the CV, you look and you say, like, how can this person provide value to our group? And unfortunately, when you're coming out, there's very little, you know, like it's not, they could come from the best place in the country, and that's great. But in the beginning, for the first 6 months that they work in your practice, they're actually going to cost you money. And it may even be the first year until the payers catch up and all this other stuff. But, you know, you're kind of growing, and these are the things, like when you're looking at a job and you're looking at this, you want to know that you have partners that are going to help you, you know, get that going. And unfortunately, I could tell you, like, you know, we have 9 interventional radiologists, and we've had plenty come and go. Sometimes you give people the keys, but they don't know how to drive, you know. And I don't want to be negative about this, but I would say a lot of people will find a crossroad and they'll go, wait a minute, do I want to put in the extra effort to have this case where, you know, where I'm the PAE guy or the UFI guy or the IO person or whatever, or am I like content making $450 a year, kind of like going to work and doing my thing? And everybody's got to figure that out. And I myself have had that. Mary and I have talked about this. I've had that up and down sort of cyclical opinion about what I want my job to look like a dozen times, you know, and, you know, like different stages of my life, right? I didn't have kids when I started this. Now I got 3 kids, and, you know, and all this other stuff, different stages of your life. I'm sure Srini could talk to this. Like, he's back in kind of an academic thing with a little bit of a hybrid practice going on. I'm sure that was like an evolution of like, well, where do I want to be right now at this stage of my life? So, so I think, like, again, it comes back to that 95% of you are going to join a practice like mine, and you got to kick the tires, and you got to try to and it won't be like mine. Actually, you're going to do garbage, like, and people probably will ask you to do some diagnostic radiology, because you're not yet providing that value and you don't really know where things are. But if during that period of time, you keep your eyes open and you work really hard and you say, you know, this is how I want it to be, you can either figure out within your group, can you make that happen? Or do you have to go, you know, do you have to try the OBL water? Again, I just talked too much, but that, you know, that's a little bit of like, you know, some of the things in here, like, oh, like, let's go off and start your own OBL. I'd be, you know, if somebody comes into our territory right now to start an OBL, which we actually have, as the big group in town, I'm going to stomp them. And like, I don't have to worry about all this other stuff that you guys were talking about. And the thing is that I can show quality, I can show access, I can show, you know, I can show that we have subspecialists that, you know, like, not somebody who comes in is like, oh, well, I'm going to do a UFI. And it's like, oh, that's cool. Here's my data. I can show you how many we did last year, you know, what our outcomes look like, you know, and oh, by the way, we've got multiple locations that we can do it at, and we're open 24/7. You know, I mean, like, these are all things that the OBL people definitely have to consider. I heard Mike Cummins one time say this quote, which really resonates with me, and it sort of puts me where I'm at, but that, you know, when you go off to do OBL, you're like the roach at the feet of dinosaurs. And what you're waiting for is the crumbs to fall down. And the good news is that the crumbs are really good. But I think, like, that is the thing. Like, I work for a public community hospital that owns the town, and anything that comes in, you know, the line is kind of drawn where the level that we are at. And I'm not saying that they're the greatest. I can't stand the hospital administrators, but if I thought about doing an OBL in my community, like, I got to figure out where I'm going to position myself amongst those dinosaurs. And the fact that I've been doing this now for almost 15 years, I think would position me a lot better to do an OBL than if I was just coming fresh out.
So I have to kind of chime in. I'm going to be a little bit of a defender of OBLs just because we want to have different perspectives. I know in St. Louis, I know in St. Louis, if I wanted to do a PAD heavy, if I wanted to join a PAD heavy practice, or I wanted to do like a 100% IR, I would only be able to do it probably in the two universities. And both universities, which is we're very fortunate in St. Louis, both universities are building PAD programs. I know Carlos on Guevara at WashU, and I know at SLU we have obviously Keith, my buddy Keith. But it's difficult to do, and so sometimes, yes, not everywhere. It's not every, you can't just say I want to build an OBL wherever you are because I love the weather. I mean, you have to also kind of look and see if there's, you have opportunity. But I will say that what you should be willing to do to build a practice in an OBL setting has to be, way more than what you would, the kind of effort you would give in a consolidated practice or like an academic practice, et cetera. You should be willing to do more things. You should be willing to put yourself out there more. In St. Louis, we're very consolidated. We have lots of hospital systems, lots of big hospital groups. We even have consolidation of primary referrers, including podiatrists who have coalesced to join and build a vascular center. And still, my volume is growing. And what, we talk about obviously we talk about quality and stuff like that, and that's fine. No one really knows your skills until you get in. But once you put yourself out there and people know that you are really, really passionate about what you do, it can resonate. And a lot of physicians, even when they consolidate, they still send stuff to me because they're like, well, I think you're the right person to do it. It's tough to do. It's not easy to do, but it is the best job I've ever had. I remember Georgie told me this, and I have it written down because I wanted to make sure I said it. Georgie said, when I was so Georgie's been calling me since I was a resident. She just stopped when I became an attending. He feels like I don't need him anymore, but I do. Especially that one day I called you with that one case. But he told me, you need to get closer to primary referrers and direct to consumer. And I always remember that. And, sometimes you don't know how your mentors impact you. I've told Mary several times, I listened to her lecture in 2013 and I got stuff from that. If your only means of getting patients is after the fourth person touches it, so the primary care refers to podiatrist, the podiatrist to a surgeon, and then to you, or to a cardiologist and to you, it'd be hard to build a practice. You have to get closer to the primary source. So for instance, now your veins and euphies, I get most of my veins and my euphies direct, to consumer, straight from the street. Actually, when I looked at my practice, the last, 6-7 months, most of my referrals are direct to consumer. So it doesn't really matter if who I'm competing with, because people find me either from word of mouth, or they've heard about me from somewhere, or whatever, they've talked about me in the local church. That's real. I mean, when you gain real traction, you help people would find you. And so for me, there are hospitals around, but people find me, and most insurance companies don't require a primary referral. And if they do, I call the primary referrer and say, hey, your patient came to me, has PAD, monophasic flows throughout, ABI 0.2. She has rest pain or ulcer in the lateral foot. She needs help. Can I help her? And send me a referral. So there are ways to kind of navigate this. Not to say it's easy or not, but definitely in a highly consolidated place of St. Louis. And I'm telling you, we're highly consolidated. I mean, we have a modern vascular here that consolidated half the podiatrists in the area, and still I'm getting busier. So I just feel like you have to kind of find your way, find your place, and also do a lot of research before you open an OBL. And also remember that you don't have to have you don't have to build an OBL. You can join an OBL. So if there are people that might be looking for help, and then you can have enjoying the spoils of working in an OBL without necessarily starting an OBL. It is expensive to start an OBL, but there are ways to get it cheaper, to do it cheaper. I pretty much built my OBL almost for free. I also, I have probably the best C-arm money can buy. It's a Philips, it's a Siemens unit with 250 MA, spits out 250 MA. It's the best you can probably get without getting a fixed unit. But yes, there are limitations to using a C-arm. You can get a fixed unit, you can get a refurbished fixed unit. That could potentially help you if you want to do a lot of PAEs and you're comfortable doing it in a C-arm, but there are ways to kind of navigate it. I think there's definitely, OBLs are expanding, they're not shrinking. So there are opportunities, people are still building them. And there are opportunities to get in that space, but I would definitely not recommend it straight out of, except you come from different programs where they're PAE heavy and there's good mentorship, like some of them I mentioned in the chat. Don't go straight to an OBL right after fellowship. The other thing too about OBLs is that people that hire people with OBLs, they want productivity. So you're just not going to get a check, and people say, well, just for you being you, I'm going to cut you a check of $500,000 or more. You have to be productive. So some people are very uncomfortable with working based on production. And that's the problem, I think, with IRs. We expect that everything would just be given to us. It gets us in trouble. One last comment I'm going to say, because I really want to get this off. It's very important. So my very best friend, he was actually the best man for my wedding. And we talk every day. He's an interventional cardiologist in the Atlanta area. When he started his practice, he knew nothing about PAD. And people will call him for PAD stuff. And he said, well, there are IRs there, and the IRs were not doing anything. They were kind of like reading and just kind of waiting for things to fall in their lap. And so he built probably the busiest PAD program they had in that hospital, making $1 million a year on RVUs. And then he went out and did his own OBL. So there are a lot of hospitals like that where IRs just kind of like sit down and they don't go out and show themselves and build a practice. And then you have an IC guy that comes in, really has no experience, and just learns on the job, and he takes over. So just kind of remember that the reason why he's so motivated to do that is that he was not promised $500,000 off the bat. It was based on revenue, based on RVUs, and so he had to look for opportunities, and he found opportunity in PAD, and he built it while the IRs were caught sleeping. So I want us to kind of, as a community, be more proactive in building practices, and that's why I like the OBL setting.
Okay, awesome. Yeah, we covered a very, very wide range of topics just in that discussion there. And we also have a lot of side conversations going on in the chat. Thank you so much to our panelists, and also Dr. Kavi Devlupalli for taking all those chat questions. I think we're running a little bit over time here, but let's just go into one last question for this session. Sort of looking into the future, what do you all think is the future of OBLs and ASCs? Do you think this market is going to grow? Are reimbursement trends moving in a favorable direction? Or do you think most OBLs are going to get bought out by private equity groups? I think Dr. Lee was also touching on that topic as well. So what, if you can look into your crystal ball, what do you all kind of think is the future?
Reimbursements have been cut.
Like many lively discussions in the private practice group. And the private practice task group that we have now through SIR, it includes people who are funded by private equity, and I mean, just every type of person. And I think all of us spend a lot of time debating it. I have no answers, but I do not understand how the OBLs are just going to continue to expand. And yeah, probably there'll be a lot of people investing in them. I think most of us could probably like walk out our front door and get private equity offers if we wanted them. But I'm hopeful that the like independent practices can still exist.
So there was a 10% cut to PAD procedures this year. So it's always a struggle each year, kind of like looking at the countdown. And my idea of the countdown is a lot different from y'all, because once it counts down and gets to January 1st, my reimbursement may go down. But I think if you're savvy at kind of like maintaining your overhead, there is still a lot of opportunity. As far as expansion of OBL and ASCs, it's hard to tell. I mean, that's the risk you take. So that's why the reward has to be, risk and reward go hand in hand. This is a fundamental business concept, and you have to have equal risk for every reward, or equal risk with every reward you get. So the reward is great with OBLs if you're actually successful, but we also understand that there is a high amount of risk, and there's no way to really predict the future, I think.
I'll tell you, I have a little bit different perspective. So when you look at the 5 major healthcare systems in our area, from really Palm Beach County all the way down to Miami, all of them want outpatient medicine, outpatient centers, facilities, etc. In a hospital case, they want ASCs, right? They're not willing to build a lot of them. They're not willing to put the money in to do that. So what's happening is the physicians, regardless of specialty, are pouring into this space down here right now. And, there's literally 3-4 opening up every few weeks in different parts of, whether it's Miami all the way up to Palm Beach County. And so I think the OBL space, the ASC space, is going to be huge over the next 10 years. I think reimbursements are going to be a struggle. And I think what's going to happen is I think hospitals are going to look to purchasing a lot of these that are existing and working in order to kind of add that to their system, because it's amazing the bureaucracies in these hospital systems when you sit in these meetings and so forth, and they might have great ideas of what they want to do, but when it actually comes to the execution, it is very difficult for them to execute because there's so many pressures from so many different facets within the hospital system. I think what Mary said is right on. I already know a lot of VCs that are already calling. I get called constantly from companies and people with these VCs who want to invest money. But when you get into the OBL space, remember, if you don't have significant ownership in these things, 1, you don't have control, and 2, you aren't seeing the best of the finances. There's people that'll call you from, there's a job in California in Bakersfield. He loves to hire IRs. It's a cardiology practice, very busy. And he's like, I'll pay you $750 to come and work. But at the end of the day, that just tells you how much that person is making off of what you're doing. And obviously they've got RVU and production quotas. So it's not like you just show up and do 2-3 cases and you're done. He's talking 8 to 12 cases a day. So that means you are busting your butt working all day. I'm not sure that's a better lifestyle. I think what Justin said about, him having 8 weeks of vacation, or in some of my older practices, 12 and 15 weeks of vacation, getting a steady paycheck. You have a lot of support from DR and the rest of the practice, even though you have other issues you got to deal with. That may be the right, decision for some people. I think the outpatient world is not for everybody. And one last thing I'll say is, I think in general, medicine is moving outpatient. That's what patients want. That's what healthcare, that's what insurance companies want. The number of patients I get referred where their insurance companies say, oh, you're in the hospital. No, we don't want them to come see you, because at the end of the day, hospitals charge a lot more, believe it or not, under the hood. I might not get paid that, but the hospital is making tons of money. So those are all things. And then the other thing you got to consider is it's not that easy to get transfer agreements. If you have an OBL, you got to be able to get privileges at hospitals, or at least transfer agreements. And in South Florida or in other parts of the country, it's easy. And in some places it's very hard. So there's a lot of things to think about.
Well, I think one of the things that's interesting is this concept that like private equity is something that's brand new. And I don't know if people actually understand what private equity means, but to distill it down, it's basically that you're creating value, and a group of investors wants to capitalize on that value by looking at how they can do things like improve inefficiencies or whatever it is. So basically, a private equity group brings a lot of cash, sets up and takes care of things like HR and overhead, and by consolidating, allows them to negotiate better on contracts and that type of thing. So it takes all of that out, but unfortunately now it's a line item in your practice. So, they come and they buy your OBL or they buy your radiology group, and now they take 30% off the top as their, them getting back to you, or getting back to them a portion of their investment. And how that works in a radiology group usually is that you restructure a contract so that the original owners will get a multiple of whatever that practice was valued at. So the people who are there first benefit financially, and then the subsequent people have to fit into the new business model that has to take into account that 30% loss of revenue that goes now to the private equity group. And I agree with everybody here. OBL is the way it's going to go. Hospitals are actively looking into this because they know that they are the high cost provider in a community, and insurance companies are steering patients away from high costs. I worry that as the hospitals get into this, they're just going to screw it up because they've got, they're paying for the pediatric patient that doesn't get the reimbursement, and they need to figure out a way to play that shell game. And they've got very high overheads. And if anybody's interested, I have a whole slideshow on how this works. But having said that, I do think that provides an opportunity, because when you, for IRs, and is that when you get down to it, right, you should be practicing good medicine. And in my view, I make a lot of money doing some really crazy things that sometimes I just have to stop myself for a little bit when I get all spun out of control about which administrator is pissing me off, or, the fact that I have to do a lumbar puncture and, I'm too highly qualified to do that, and when it comes down to it, like, there's a huge opportunity there, even if it's not at the time of day that I want to do it, or, whatever. I mean, like, there's a patient there, and I can, put myself in the situation and do it and do a good job. And I'm not saying that works out really well. Like, when you get that phone call at night, like, I usually get pissed and I am depressed for like the first 5 minutes of the drive. But usually when I leave the hospital, I don't feel bad. Maybe I'm like thinking like, oh, well, tomorrow I'm not gonna be able to go on a run at, whatever time, but I usually still feel like I did the right thing. So with all of this stuff, none of us can really forecast how it's going to be, but in the future, because I never saw where I'm at right now. When I was in training, I didn't even know what half the things that we talked about here were. But in the end, like, I get an opportunity to do some really cool things, and I think if I wanted to just sort of be a slug and show up and work and whatnot, I would get a paycheck, and it's a really good paycheck. I choose to want to start a PAE practice. I don't get paid to do it. I choose to do it because I like to do it. And there are ways to do it within any number of the things that were discussed here today. And it's funny now, there was a time when I was trying to tell Spies that, like, we should just leave and open up our own department of interventional radiology because we're so much better than these DR people and we add all this value. Well, I do diagnostic radiology now later on in my career because I don't really mind that much doing it. And to be honest with you, my DR, the work that I do in DR really promotes cases that I get later on. I mean, it's like, it's so fluid, and this conversation could go on forever, but I think that ultimately when everybody who's here is thinking about what they want to do, if you focus back to the joy that you get, from doing some of these cases, and having that output, versus like, and this is what I would caution people against. Like, a lot of times we interview these people and they want to make $450 a year and they want to have 12 weeks of vacation. You know, when I came out, my starting salary was $215, and I was just as happy then as I am now, where I earn, well above $5. And in fact, I maybe was a little happier back then, than I am now. So if you pause a little bit and think about what your next step is going to be after fellowship, and you don't worry too much about the PE, you don't worry too much about, like where exactly, maybe where you're going to practice matters if you're near your family and all that stuff, but you think like, how can I integrate into this practice? Can I bring value and do this? Can I help the guy who's there or gal who's doing UFI? And I've done a lot of them and help them, that may be the better way to do it than trying to like take all these different permutations of an IR practice, be it academics, private practice, OBL. And then later on, think about like where you want your professional life to be. I think that'd probably be the best way to do it.
Awesome. A lot of wisdom shared today during this session, but I think that brings us to the end of our talk today, and also to the end of the WCVIR Symposium. It's been a pleasure. Thank you so much to our panelists for spending time with us today on Super Bowl Sunday, and thank you to our audience for tuning in. We had a really great turnout this year. I think almost double last year's turnout. It's been a great learning experience. Good to see familiar faces. And I want to give a big shout out to Navjeet Dalit, who is PGY4 at University of Arizona. Navjeet, you did an amazing job leading and organizing this entire symposium. Thank you so much. So I'll hand it off now.
Thank you very much, Subhash. Thank you very much for all of the private practice panelists and Dr. De Villapalli for joining us as well. Really quickly before we close, I'd like to give some additional honorable mentions for the Angio Club that we had yesterday. Some of the other great cases that we had was a case of complicated aortic dissection repair by Delaney Aguilar, who is a medical student at Western University in Oregon. UAE for placenta accreta by Jeff Wellard, who is a medical student at University of Arizona in Phoenix. Acute mesenteric vein thrombosis by Tong Chi, who is at Kaiser in Los Angeles. Pulmonary AVM embolization by Troy Senders, who's a medical student at UCLA. Thyroid ablation case by Lindsay Webster, who is a medical student at Emory and one of our organizers. And also uterine artery embolization for a uterine AVF by Sagar Desai, who's a integrated resident at Einstein. I'd like to thank all of the organizers, panelists,